Hello, good evening, good evening, everyone. Uh, Today we'll start our discussion on coma, and we are continuing our series of neurological symptoms from Harrison based. Okay, in last class we have studied raised ICP because before we move on to coma, we should have a clear understanding of what is raised ICP, what is uncal herniation, and in last class we have done all of these, na raised ICP, uncal herniation. So, okay, so if audio is clear, just give me a thumbs up. Then we will proceed further. Everyone, just give me a thumbs up. लास्ट लेक्चर में किसी को डाउट थी रेज्ड आईसीपी और अंकल हर्निएशन में जिसमें हमने पढ़ा था? इफ एनीवन हु हैव गॉन फ्रॉम लास्ट लेक्चर, किसी को डाउट रेज्ड आईसीपी? ओके ओके विपुल कुमार, थैंक यू विपुल कुमार जी, नमस्ते। ओके वेंकी, तो थैंक्स डॉक्टर विपुल। तो लास्ट लेक्चर में किसी को डाउट थी रेज्ड आईसीपी में और अंकल हर्निएशन में? ठीक है, लास्ट क्लास में वी हैव सीन दैट हाउ रेज्ड आईसीपी अफेक्ट अस एंड हाउ uncle herniation affect us. So before I proceed further, uh, a small a small clinical a small clinical question related to raised ICP. Hi Naji. So a patient coming to you in your casualty, you have gone with examination. Patient was having headache, and when you have done fundus examination, when you have done fundus examination, you have find that one side one side of pupil is dilated. One side of pupil is dilated. So patient was having headache, fundus examination, one side of pupil was dilated. Patient suffer a road traffic accident, RTA, and patient was having a brain injury. So anyone can tell me how will you proceed this patient? How will you proceed with this patient? Patient was has suffered from a road traffic accident. Hello, Aunt Peggy McDonald. So patient was having has suffered from a road traffic accident. Patient was having a brain injury, present to you in casualty with headache, anisocoria. Yeah, one you have done a fundus examination, pupil examination. You are finding that one side of pupil dilated. Now, how will you approach further? Anyone can further tell me how will you approach this patient further? Because if you are not approaching this patient as quickly as possible, then patient will land into coma. Today our lecture is all about coma. But can we prevent anyone in going to coma? So patient was having headache. On fund exam, one side of pupil was dilated, and patient suffered from RTA brain injury. So what is this patient? This is the patient of raised intracranial pressure. In last class, we have studied that due to third nerve damage, there is pupil dilation. There is dilation of ipsilateral pupillary dilation was there. So one side pupil is dilated, headache was there, raw traffic accident history is there. So what you will suspect? Yeah, this is a patient of raised ICP. And what you will do? You will give treatment of raised ICP as quickly as possible. If you are not giving patient treatment as quickly as possible, what will happen? Patient will land into coma. So you have to act as much quickly as possible. Okay, everyone, got this point? How do you will deal with a patient of raised ICP and how can you protect that patient to going into coma? Just give me a thumbs up if you have cleared with this concept. Okay, everyone. Anyone किसी को डाउट इस कंसेप्ट में कि रेज्ड आईसीपी पेशेंट को हम न्यूरोलॉजिकल एग्जामिनेशन में हाउ वी विल सस्पेक्ट दैट दिस पेशेंट इज हैविंग अ रेज्ड आईसीपी एंड हाउ डू विल ट्रीटमेंट? इन ट्रीटमेंट इट इज जस्ट बेड एलिवेशन, it is bed elevation and hello Arya, Nag, and osmotherapy, that is your, mannitol. Good evening, Rishali. Good evening, everyone. So, in this lecture, we will be studying coma. Our main aim is to diagnose coma, but we also have to prevent patient from going into coma. So, a patient come to you in casualty, his attendant and relatives are telling to you that, sir, patient was driving and suddenly patient experienced a road traffic accident. Patient was having brain injury. He was having headache. On examination, what you are finding? You are finding that one side of pupil was dilated. Why pupil was dilated? Because of third nerve injury. In last class we have studied there is in raised ICP there is third nerve dilation is due to third nerve damage there is pupillary dilation. So what you suspect? You are suspecting raised ICP, and in that patient you have to act as quickly as possible because if you will not act as quickly as possible, patient will land into coma. Patient will land into coma, and many times coma are irreversible. So you have to act as quickly as possible. You will do bed elevation, you will give osmotherapy, mannitol, and other treatment option which we have discussed in last class lecture of raised ICP. Okay, so in this class we will study about coma. So can anyone tell me how do you define coma? What what do you have learnt about coma in your MBBS year? Anyone can just tell me what do you think when someone say that this patient is in coma? Anyone? What do you think when someone say to you that yeah, this patient is in coma? Anyone? Okay. So, Harshita is saying it's the loss of consciousness. बेटा लॉस ऑफ कॉन्शियसनेस तो सिंकोप में भी होती है. लॉस ऑफ कॉन्शियसनेस तो सिंकोप में भी होती है. नो नो नो, कोमा इज नॉट अ लॉस ऑफ कॉन्शियसनेस. लॉस ऑफ कॉन्शियसनेस तो बहुत चीजों में होती है. स्ट्रोक में भी लॉस ऑफ कॉन्शियसनेस होती है. हाय नवीन पटोला, हाउ आर यू? सो कोमा इज इट इज अ हाँ good. Harshita is like for a long duration. So it is a deep sleep like when someone does not respond to external environment. Okay, we can say that if someone not respond to external environment, it is a unresponsive to stimulants. Yeah, this is one of the correct way that patient is unresponsive to stimuli. So it is a deep sleep like state from which the patient cannot be aroused. Okay, it is a deep sleep like state from which the patient cannot be aroused. Or in short term, we can say that normally eyes closed, normally eyes closed, and unresponsiveness. So you are going in your ward duty, you are in casualty, you are finding some patient whose eyes are closed and he is in unresponsive. What you will suspect? You will suspect coma. Yeah, yeah, Deepika Palai, it can be in autoimmune disorder also. If suppose if there is a patient of multiple sclerosis and you are not treating him properly, eventually in the course of time he will land into coma. If a patient of autoimmune encephalitis is there, that patient can also land to coma. But these condition, autoimmune condition, condition which leads to coma, they can be reversible also if you treat them properly. So it is a deep sleep-like state from which the patient cannot be aroused and normally eyes closed and unresponsiveness. So how do we define consciousness? So consciousness has two things. First is your arousal. Okay. Now arousal is done by it is done by a function sustained brainstem. It means arousal means awakening. What do you mean by arousal? Awakening. So if your brainstem is normal, if brainstem is functioning, what is brainstem? Midbrain, pons, and medulla. So if your brainstem is okay, then there will be no problem in arousal. And we will study that how brainstem help in arousal in upcoming slides. Okay. Second is cognition. It is done by cortex. Can anyone tell me what do you understand by term cognition? What do you understand by term cognition? Anyone? What do you understand by term cognition? What do you understand by term cognition? Anyone? It is coherence of your thought. Cognition means you can understand all things, you can do all things. Okay? Yeah, good Navi. You can understand things, you can done things, you can be intellectual also. As suppose when you were a small child, but now you have grown into adult, your cognition power has increased. You can intellectually think up in a better way. You can understand things in a better way. This is your cognition. No, no, Rishali, cognition is not coordination. No, it is your intellectual thinking. How can you understand a particular thing? It is done by your cortex, and arousal is done by your brainstem. So we have understood that in consciousness, two things play a role. One is your cortex, and second is your brainstem. So, so, so to say a patient is in coma. So when we will say a patient is in coma, so there are two things. There are two things. Okay. So first is your cerebral hemisphere. Cerebral hemisphere. And a patient to be in coma, your bilateral cerebral hemisphere should be damaged. Should be damaged. So, for you to lose consciousness, for you to be in coma, your bilateral cerebral hemisphere should be damaged, not a single one. Your bilateral cerebral hemisphere should be damaged. Has everyone got this concept? कि अगर हमें कोमा में होना है, अगर हम बोल रहे हैं कि ये पेशेंट कोमा में है, तो इसके दोनों सेरिब्रल हेमिस्फीयर डैमेज होंगे. अगर कोई पेशेंट, if there is a patient who is in coma or in a loss of consciousness for a longer period of time, it means that its both cerebral hemisphere will be damaged. Now you will be asking me a point, sir. We have studied that there are two kinds of stroke. One is cortical stroke, and other was subcortical stroke. Other was subcortical stroke. And in subcortical stroke, there is no loss of consciousness. But in cortical stroke, you have said that there is a loss of consciousness. Yeah, I have said that in cortical stroke, there is loss of consciousness. But if suppose, if suppose there is a stroke on right side only, there is a stroke on right side only. Okay, and that is also of a big artery. That is a middle cerebral artery stroke is there, suppose. So can this unilateral stroke produce loss of consciousness? No, it can't produce loss of consciousness. It can only produce loss of consciousness when there is रिशाली लाइक सर, अगर दोनों कॉर्टिकल हेमिस्फीयर डैमेज होते हैं तो कुछ लोग कोमा से बाहर कैसे आते हैं? रिशाली सी, इफ योर both cerebral hemisphere are damaged, it means there is some structural damage to your brain. But there are many other reasons for coma. Suppose if there is a patient of diabetes and he is going into coma due to diabetic ketoacidosis, then you can manage that patient, and that patient can be reverted back from a coma to a normal state. If there is a patient of stroke, if you manage him properly, he can be bring back from coma. If there is a patient of hypoglycemia and you correct his or her sugar at that time, you can bring that patient from coma to normal. So there are some irreversible causes and there are some reversible causes of coma. In irreversible cause of coma, you can't bring back the patient. But in reversible cause of the patient, you can bring back the patient. Okay, Rishali, I think you have got that answer. So I was saying you about cortical stroke. So in cortical stroke, there is the loss of consciousness. We all have studied, but normally, what when we study the stroke, we say that is a unilateral stroke maximum time. So if a stroke is on right side MCA, can it produce loss of consciousness? So normally, unilateral strokes can't produce loss of consciousness unless and until it has a large cerebral edema, large cerebral edema, which is doing midline shift, which is doing midline shift. Only then it can be a loss of consciousness only. So we have seen that there are many patients with stroke, but does all patients with stroke has loss of consciousness, or all patients with stroke has gone to coma? No, only if there is a bilateral stroke, because in bilateral stroke there will be a bilateral cerebral hemisphere damage. Only patient who are having bilateral cerebral hemisphere damage, only these kind of patients go in stroke, or sorry, goes in coma or goes in loss of consciousness. If there is a unilateral stroke, then patient can go in loss of consciousness or coma only when there is a large cerebral edema which is doing a midline shift. Okay, everyone, everyone has gone this point कि कोमा कब होगा? जब बायलेटरल सेरिब्रल हेमिस्फीयर डैमेज होंगे. अगर यूनिलेटरल पे अगर कोमा हो रहा है, इट मींस कि cerebral edema was so much large that it was doing a midline shift. Everyone got this concept? Just give me a thumbs up. सबको ये बात समझ में आ गई कि कोमा के लिए क्या होगा? दोनों हेमिस्फीयर डैमेज. So Dheeraj is asking, sir, what is midline shift? Beta Dheeraj, I have taken last lecture on raised ICP. In that lecture, you can go and study midline shift. But in this lecture, I will just brief you about midline shift. Suppose this is your brain, okay, beta, and these are your hemisphere. Suppose, okay, these are your hemisphere. Okay, this is your right and this is your left. Then, yeah, pressure causes the midline shift. And suppose there is any trauma, there is any bleed or hemorrhage on this right hand side. So, and this is your midline. ये आपकी क्या है बेटा? ये आपकी मिडलाइन है. तो जब राइट हैंड साइड पे प्रेशर होगा, व्हेन देयर विल बी प्रेशर ऑन राइट हैंड साइड, व्हाट विल हैपन? दिस राइट सेरिब्रल हेमिस्फीयर विल गो टू लेफ्ट हैंड साइड and it will be like this, and there will be a midline shift. Okay, Dheeraj, have you got this? How midline shift occur? If there is a lot of pressure, brain will shift from right side of brain will shift from right side to left side. So if there is a patient who is in coma and due to a unilateral damage of cerebral hemisphere, he can only be in coma due to a damage of unilateral cerebral hemisphere when there is a large cerebral edema doing midline shift. And we all know from last lecture that midline shift is also known as subfalcine herniation. So, so Rishali was asking about कि कुछ लोग अगर कोमा में जाते हैं तो उनका सो. अरे वो, there was a serial earlier now on एनडीटीवी इमेजिन, वो पिछले जन्म में जाओ, आप अपने पिछले जन्म में जा रहे हो, सोचो सोचो आप पिछले जन्म में क्या कर रहे हो. सो इन these kinds of serial only these things happen. In practical, in my whole career of being a doctor, I haven't seen something like कि पेशेंट कोमा में है and उसका सोल वापस आ रहा है. Our main concern is to save the patient, not to deal with the soul of that patient. Okay, Rishali. And about soul, coma, and body, we will. Uh, no, 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 Arya, we will take a class on soul also, na? What happened to soul when patient is in coma? Okay. Uh, Dheeraj is asking how midline shift contribute to loss of consciousness. Okay, beta. Beta, see, what I have told you that your consciousness is maintained by your cerebral hemisphere. Okay. And when both cerebral hemisphere are damaged bilaterally, it leads to loss of consciousness. Okay. When there is a unilateral damage, and it damages such like that it is producing a midline shift. It is producing a midline shift. So what do you understand by midline shift? That your both cerebral hemisphere are getting compromised. Your both cerebral hemisphere are getting compromised. So that's how midline shift contribute to loss of consciousness. Because if you are having midline shift, your both cerebral hemisphere will be getting compromised, na beta? So you will get loss of consciousness. Okay, Dheeraj? Okay, Rishali, but actually, sorry, na, but I don't have any knowledge about this concept. बेटा करंटली यार मेरे को तो इस टॉपिक पे ना देखो कोई कोई भी नॉलेज नहीं है. तो मैं आई आई थिंक अगर आपके पास कोई सोर्स है, कोई आर्टिकल है, तो आप जरूर मतलब यू शेयर दिस टू अस ना, एंड वी विल स्टडी एंड वी विल कम विद दिस आल्सो. ओके बेटा विशाली. Right now I don't think it's not about laughing, but I am not having knowledge on that topic na, so how can I comment on that topic? So I will study about this topic. Rishali has told to us. We all will study and then we will tell our points. Okay, Rishali, shall we move further? Okay, beta, you tell us name. Okay, we will are moving further. So we have seen that coma is produced by when there are cerebral hemisphere damage bilaterally. Other thing, or coma can also be produced when there is damage to brainstem. When there is damage to brainstem, and I have told you कि brainstem helps us in arousal. Brainstem helps us in arousal. So, what is the structure in brainstem? If that is damaged, it leads to coma. That is your reticular activating system. That is your reticular activating system. That is your RAS. Okay. It is also known as thalamocortical alerting system. It is also known as thalamocortical alerting system. So, can anyone tell me about reticular activating system? We all have studied that coma किस वजह से होता है? Either due to bilateral cerebral hemisphere damage or due to damage of brainstem, and in brainstem, reticular activating system. So, can anyone tell me what do you mean by reticular activating? It is a relay system for stimulus. No, Dheeraj. Anyone? What do you mean by reticular activating system? Can anyone tell me what do you mean by a reticular activating system? So, basically, what is your reticular activating system? See, if This is your cerebellum. This is your brainstem. This is your midbrain. This is your pons, and this is your medulla. Okay. In this, a system is there in brainstem that is known as reticular activating system (RAS). It has some connection with thalamus. It has some connections with thalamus, and these connections then project into whole cortex. See, this position projecting into whole cortex. So, reticular acting system helps you in arousal. When you are sleeping, and from sleeping you suddenly wake up. When you suddenly wake up, which system is activated? Your RAS system is activated. So, when you are awake, your RAS is activated. Your RAS gives stimulus to cortex. Ki, be awake, be awake, जाग जाओ, be awake, जाग जाओ. So there is a system in your brainstem that is reticular activating system, which wakes up and fires when you are arousal, when you are not sleeping. It is only not firing. It is only not firing at the time of sleep. At the time of sleep, it is not firing. But when you are arousal, when you are awakened, this system fires quickly, and it gives its fire. It fibers to thalamus, and from thalamus fibers reach to whole cortex. You see, okay, everyone is seeing this concept that there is a reticular activating system. Its fibers are projecting in thalamus, and from thalamus, these fibers are relaying into whole cortex. Oh, Rishali, we will discuss about this at the end of lecture. Okay, beta. So, has everyone got the concept of function of reticular activating system? भाई मैं सो रहा हूँ, अब मैं सोते सोते एकदम से उठ गया, तो जब मैं उठा हूं तो क्या एक्टिवेट हुआ है मेरी बॉडी में? रेटिकुलर एक्टिवेटिंग सिस्टम. रेटिकुलर एक्टिवेटिंग सिस्टम के फाइबर कहां पे जाते हैं? थैलेमस में, एंड थैलेमस प्रोजेक्ट इनटू होल कॉर्टेक्स. दैट्स व्हाई व्हेन यू गेट अवेक योर कॉर्टेक्स आल्सो अवेक, एंड यू नो ऑल द थिंग्स ऑफ योर सराउंडिंग्स. ओके, तो सबको रेटिकुलर एक्टिवेटिंग सिस्टम का फंक्शन समझ में आ गया. whenever you are awakened, your reticular activating system awakes, and reticular activating system fires in such a way that your cortex get all your innervation, and you are aware of your surroundings. You are aware of your surroundings. So when you are awakened, your reticular activating system is on, and when you are sleeping, your reticular activating system is off. तो जब मैं उठाऊं, सो के उठाऊं, तो एकदम से क्या एक्टिवेट हो जाएगा? मेरा रेटिकुलर एक्टिवेटिंग सिस्टम एक्टिवेट हो जाएगा, वो मेरे कॉर्टेक्स को क्या कर देगा? एक्टिवेट कर देगा. दिस इज द फंक्शन ऑफ योर रेटिकुलर एक्टिवेटिंग सिस्टम. So see, now we will see how formation we will see the formation of this reticular activating system. ठीक है, फॉर्मेशन कैसे होती है? सी, देयर इज डायग्राम. This is your midbrain, this is your pons, this is medulla, and your spinal cord. Okay, everyone, got this diagram? ठीक है. Can anyone tell me कि gray matter spinal cord में inside it is in center or periphery, and gray matter cerebral cortex में it is in periphery or center? ग्रे मैटर, आई एम रिपीटिंग माय क्वेश्चन, कि ग्रे मैटर सेरिब्रल कॉर्टेक्स में पेरिफेरी में होता है, सेंट्रल में होता है, और स्पाइनल कॉर्ड में किधर होता है? सेंटर में या पेरिफेरी में? जस्ट टेल मी एवरीवन. सो योर ग्रे मैटर इन सेरिब्रल कॉर्टेक्स इज इन पेरिफेरी, इज इन, नो 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 धीरज, ग्रे मैटर स्पाइनल कॉर्ड में सेंट्रल होता है, बट सेरिब्रल कॉर्टेक्स में पेरिफेरी में होता है. सी, दिस इज योर ग्रे मैटर. ओके, एंड दिस इज योर gray matter in spinal cord. This is your gray matter in spinal cord. Okay, this is the gray matter in spinal cord, and this gray matter is like this. Okay, now we all know that from gray matter, what arises? From gray matters, your tracts arises, your motor tract is there, your sensory tract is there. Now suppose if a tract is coming, if a tract is coming, okay, and if a tract is coming, but when you go to spinal cord, your gray matter is in center. So when this tract go and mixes with the gray matter, your tract goes and it get mixed with the gray matter. It get mixed with the gray matter. So the mixing of white matter tract with the gray matter in your brain stem, it is known as your reticular system. सबको समझ में आया रेटिकुलर सिस्टम कैसे बनता है? जस्ट कोई डाउट है, टेल मी. सो इन deeper part, in deeper part of brain stem, in which sensory and motor crossing is there. Sensory and motor crossing is there, because we all know that sensory fiber also decussate and motor fiber also decussate. It leads to mixture of gray matter and white matter. This is known as your reticular system. I am repeating again. Your gray matter in spinal cord was in center, but gray matter in cerebral cortex was in periphery. So periphery se tracts are coming, your motor tract is coming, and your sensory tract is also going, and these all tract decussates, so they move from frontal side also. So your gray matter was in center. So when these tracts are coming and they are decussating in opposite side, they they get mixed with the gray matter. So this mixing of white matter and gray matter in the brainstem area, it is known as your reticular system. Anyone कोई डाउट? जस्ट टेल मी इन कमेंट सेक्शन अगर रेटिकुलर सिस्टम की फॉर्मेशन किसी को समझ नहीं आई तो. जस्ट टेल मी इन कमेंट सेक्शन किसी को रेटिकुलर सिस्टम की फॉर्मेशन समझ नहीं आई. एवरीवन ओके विद दिस कंसेप्ट? Just if anyone is there who hasn't understood till now. सबको समझ में आ गया कि रेटिकुलर फॉर्मेशन कैसे होती है? सबको reticular formation is a meshwork of gray matter and white matter present in the spinal cord, which has its connection with thalamus, and then it's project into whole cortex such that we get awaken. Beta, see, your gray matter up. There is two things in your central nervous system. One is your gray matter and white matter. Cerebral cortex में gray matter is in periphery. ठीक है, सेरेब्रल कॉर्टेक्स में ग्रे मैटर कहाँ होता है? पेरिफेरी में होता है. और स्पाइनल कॉर्ड में ग्रे मैटर कहाँ होता है? सेंटर में होता है. अब सेरेब्रल कॉर्टेक्स में ग्रे मैटर पेरिफेरी, और ग्रे मैटर से क्या निकलते हैं? हमारे न्यूरॉन्स निकलते हैं जो ट्रैक्स बनाते हैं. अब ये व्हाइट मैटर के ट्रैक जब नीचे आते हैं तो इनको क्या मिलता है? सेंटर में क्या मिलता है इनको? ग्रे मैटर और स्पाइनल कॉर्ड मिलता है. अब ये क्या करते हैं? क्योंकि जो फाइबर्स होते हैं वो डिकसेट करते हैं, तो जब डिकसेट करते हैं तो ग्रे मैटर से क्या हो जाते हैं? मिक्स हो जाते हैं. तो जो मिक्सिंग होती है व्हाइट मैटर की ग्रे मैटर की, जो ब्रेन स्टेम में होती है, उसको बोलते हैं हम रेटिकुलर सिस्टम. और ये रेटिकुलर सिस्टम हमें अवेकनिंग में हेल्प करता है. हमें अवेकनिंग में हेल्प करता है. तो अगर या तो मेरा डैमेज है रेटिकुलर सिस्टम का, और या मेरा डैमेज है बायलेटरल सेरिब्रल हेमिस्फीयर का, तो आई विल गो इनटू कोमा. सो इफ एनीवन नाउ ऑनवर्ड्स आस्क यू कि this patient is in coma, then tell them, if this patient is in coma, either there are some reversible causes of coma, or if there are irreversible causes of coma, then it only can be due to either a bilateral cerebral hemisphere damage or damage to reticular system which is present in the brain stem. Anyone कोई doubt, or we shall we go further? Just tell me. जस्ट गिव मी थम्स अप अगर यहाँ तक सबको समझ में आ गया तो। सी दिस इज योर रेटिकुलर सिस्टम, you are seeing this reticular formation. So it is getting input from everywhere, from surroundings, from a visual area, from ear that you have aroused, and having all its projection into cortex. See, reticular formation is a diffused, ill-defined mass of nerve cells and fibers forming an ill-defined measure of reticulum in the central portion of the brainstem and leading to arousal. So from now on onwards, it's okay. Recursion. So if now onwards, if someone has asked you, ki, now I will tell you one term. We all have know there is a term known as brain stem death. There is a term known as brain stem death. It means brain death. It means brain death. And if there is a patient of brain stem death or brain death, so problem is in brain stem. Where is problem is in problem is in brain stem. And in brainstem, which organ is sorry, in brainstem, which thing is there which helps us to maintain consciousness? That is your problem is in reticular activating system. Okay, everyone, got this concept? Shall we move further? Okay, now see, before I move on to further in coma, we first see there are some stages of coma. There are some stages of coma. So initially you are alert. Initially you are alert, but now you are drowsy. You have last night you went la, last Saturday you went to party and you have party very much hard, so you are in drowsy. Okay, Aryan now. So initially you are alert, but you went to party, you are drowsy, and after some time you are obtunded. Then you go in stupor, and then finally you land into comatose stage, in which there is no response to deep pain also. Okay, so from alert, drowsy, obtundent, stupor, and then finally to coma. These are the stages when an alert person goes to coma. Okay, now now we will go to causes of coma, like which Rishali was initially asking us. Yeah, recreature. We will study this all things. What are you telling in the neurological examination part? Okay, beta. In neurological examination part, we will deal with all these things. Okay. So causes of coma, causes of coma can be divided into two headings. First are your structural. Okay. So what can the structural causes of coma in? What can the structural causes of coma? Just tell me in comment section. There is a patient of coma, and I am saying this patient has suffered from coma due to some structural damage to brain. Better see, in in stupor, you can you can localize if there is a deep pain. You can localize a deep pain, but in comatose you can't localize deep pain. There is one thing. And in stupor, you can give some response. You can give some response, but in comatose patient, you can't give any response. Okay, better Vishali. So Dheeraj is saying damage to RAS. Yes, either damage. No, no, Naveen, how cerebellum damage can do coma? Cerebral hemisphere damage causes, na? How cerebellum? Either it is damage to RAS or it is damage to your bilateral cerebral hemisphere. Okay. Either it is due to RAS or due to bilateral cerebral hemisphere damage. Other causes. So these structural causes many a times are irreversible. Many times are irreversible. So if there is a structural damage to brain and patient goes in coma, you can't bring back patient back to coma. Maximum time. And other causes in which patient can revert back from coma, there are your metabolic causes of coma. These are your metabolic causes of coma. So can anyone now tell me the causes of coma? Just who will enlist me the metabolic causes of coma? कौन कौन मुझे बताएगा मेटाबॉलिक कॉजेज ऑफ कोमा क्या है? एनीवन who can tell me what are the metabolic causes of coma? So Dheeraj is saying ketoacidosis. Okay, beta. First is your diabetic ketoacidosis. Okay. Arya Nag is saying hypoglycemia. Okay. Second is hypoglycemia. Okay. Other causes. Other causes. Can you think or more causes of metabolic causes of coma which are reversible? Which are reversible? Arya Nag is saying alcohol. Okay, beta. You are always in favor of alcohol. So alcohol toxicity. More. Can you think more causes? Because if you are going to see a patient of coma and you are thinking of some reversible causes, in your mind should you also be thinking the cause of reversible? Because your eyes can only see what your mind knows. Your eyes can only see what your mind knows. So think other reversible causes of coma. Anyone? कि और क्या क्या हो सकते हैं रिवर्सिबल कॉजेज ऑफ कोमा? इन्फॉक्शन. नो बेटा, इन्फॉक्शन तो स्ट्रक्चर डैमेज हुआ है ना ब्रेन को. वी आर टॉकिंग अबाउट द मेटाबॉलिक रिवर्सिबल कॉजेज ऑफ कोमा. Some drugs, okay, good. Drug toxicity, okay. Other, or if there is a patient of CLD, CLD patient में क्या होता है? Hepatic encephalopathy. क्यों? Due to rise in ammonia, and that patient can also go in coma if you are not treating him properly. Other is patient of AKI or CKD. He or she can also land in coma. Other is if patient is suffering from hypothyroidism, if patient is suffering from hypothyroidism and he or she is not taking drugs properly, he can land into myxedema coma. No, no, Naveen. How can dehydration leads to coma, beta? Dehydration can lead to shock. How can dehydration leads to coma? There are so much patient of dehydration in our country. So, and this number of patient can go into coma. Dehydration can lead to shock. It can't lead to coma. Okay. So can be DK, it can be hypoglycemia, alcohol toxicity, drugs toxicity, CLD, hepatic NCAP, AKI, CKD, mixed edema coma. So if there is a patient of coma, if there is a patient of coma, we all should remember that before labeling a patient of coma structural damage, before you label a patient of coma structural damage, you should always rule out the reversible causes of coma. I am repeating, before you. Yeah, Heather, you are right. So before you label any patient of coma, structural coma, you should always first rule out the reversible causes of coma. And to rule out the reversible causes of coma, you will do certain investigations. So what investigation you will do? First, you will do RBS to know is patient is in hypoglycemia or hyperglycemia. You will do KFT to know the status of AKI and CKD. You will do LFT to know the status of chronic liver disease or patient is going hepatic NCAP or no. You will do ammonia levels. Okay. You will check urea because CKD patient can can go into uremic encephalopathy. So you must need a urea level also. You also need thyroid profile. You need a thyroid profile to rule out mixed edema coma. You then must send all the serum electrolytes, and last but not the least, you must do a ABG. Okay, if this all thing comes normal, if this all thing comes normal, then you will do a imaging. Yeah, Dheeraj, you will do a imaging like MRI to see structural cause of coma. सबको ये बात समझ में आ गई कि हाउ टू डिफरेंशिएट बिटवीन स्ट्रक्चरल एंड मेटाबॉलिक कॉजेज ऑफ कोमा. एनीवन कोई डाउट जस्ट टेल मी इन कमेंट सेक्शन. Patient is coming to me. uh, I was sitting in emergency. Patient has come to me. Patient, there is no response. Patient is not closing his or her eyes. I was suspecting that patient is maybe in coma. So what first thing I will do? First, I will check his RBS because hypoglycemia is the most common cause a patient lands in coma. And you can easily correct the hypoglycemia by giving dextrose. So first you will rule out hypoglycemia. And you always must remember that metabolic causes are more common as compared to structural. Are more common as compared to structural. So patient has come to me in coma. I will test for DK, urine ketone, serum ketone levels. I will do serum urine and urine ketone level. I will do RBS, I will do KFT, LFT, ammonia levels, urea. I will do thyroid profile, सेम एप्लाइड करूंगा, एबीजी करूंगा. अगर हाँ बेटा जीसीएस तो करना ही है, जीसीएस तो करना ही है बेटा, वो तो आपका एग्जामिनेशन वाला पार्ट है, वो तो हम करेंगे जीसीएस. एंड इफ योर ऑल ऑफ दिस इन्वेस्टिगेशन कम्स आउट टू बी नॉर्मल, अगर मेरी सब इन्वेस्टिगेशन क्या आ जाती है नॉर्मल, तब मैं क्या समझूंगा कि if is there any structural damage to brain is present or not. So for seeing the structural damage to brain, I will do imaging. And in imaging, what I will do? I will do MRI or CT or diffusion weighted MRI to see the structural causes of coma. किसी को कोई डाउट यहाँ तक just tell me in comment section if you got how to differentiate between a structural and reversible causes of coma in your when you are sitting in emergency, because metabolic reversible causes of coma are more common compared to structural causes. And in metabolic causes, you can correct them as quickly as much possible. And if you correct them as quickly as possible, patient can come back to normal. So you always have to rule out the reversible metabolic cause of coma. I am repeating again and again. I have seen many a times doctors are sitting in casualty, and the basic investigation they can do is checking his or her RBS. If patient is in hypoglycemia, you can just correct his glucose level by giving dextrose. Okay, everyone, just give me thumbs up if everyone has understood till now. So, Dheeraj, what part you haven't understood? Just tell me. Dheeraj, what part you haven't understood? Just tell me. See, Dheeraj. Rishal is like, sir, MRI में क्या देखे sir? Better see what we will see in MRI. We will see is there any damage to brainstem or not? Is there damage to cortex or not? You have to see if suppose if there is a damage on cortex. So in MRI, you will see some hyperintensities in cortex. If there's damage in brainstem, you will see some hyperintensities there. So in MRI, we will see the damage to brainstem and cortex, because we all know that patient can go to coma in structure if there is a damage to reticular activity system, that is your brainstem, or there is bilateral cerebral hemisphere. And how can you see this structural damage? By looking to image. Okay, Rishali beta. So see, these all are the reversible causes. There is a poisoning of alcohol, or there can be hyper and hypoglycemia. It can be due to renal failure, because renal failure can lead to uremia. It can be hypercalcemia, metabolic acidosis, hepatic failure can lead to hyperammonia, endocrine pituitary insufficiency, myxedema, adrenal insufficiency, or drug overdose, likely benzodiazepine and opioids. Okay? So we have to rule out all these things. Now, there is a so many a times now. No, 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 Naveen. या parasitic infection से भी हो सकता है. If there is a pneumocystosarcosis, if patient can go to meningitis or encephalitis, so meningitis, encephalitis, if you are not treating them properly, patient can end to coma also. No, 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 Naveen, unless until shock is due to some metabolic cause, shock normally doesn't lead to coma. Okay, so you were sitting in emergency, a patient comes to you in coma, you have done his RBS, his RBS was low, you were suspecting hypoglycemia, you were suspecting hypoglycemia. You give dextrose, patient is okay. Patient is now okay. But now there is one patient. No, 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 Naveen. Shock, generally, if shock is due to dehydration part, because maximum time our shock are due to dehydration part. So generally, shock doesn't lead to coma. Unless until shock is due to some cardiac event or a shock is due to a neurogenic shock. If there is a cardiogenic shock or neurogenic shock, it can lead to coma. Your normal hypovolemic shock generally doesn't lead to coma. Now, maximum time we see that in emergency, a patient will come to you, alcoholic patient. Alcoholic patient will come to you, a roadside patient. Okay, someone will bring that patient to you, alcoholic patient. You will be checking his or her RBS, and if his RBS low, you replace with that RBS with dextrose. But patient get more worsen. Patient get more worse. So why patient get more worse? Because in alcoholic patient, can anyone tell me that which vitamin is low in alcoholic patient? I am repeating, which vitamin is low in alcoholic patient? Anyone can tell me? Can anyone tell me which vitamin is low in alcoholic patient? Alcoholic patient में कौन सा vitamin low होता है? Anyone? Anyone can tell me which vitamin is low in alcoholic patient? You all are NEETPG aspirants. Just tell me, Rishali, Naveen, Arya, alcoholics में कौन सा vitamin low होता है? There is maximum time thiamine. There is decrease in thiamine in these patients, and maximum time these patients alcoholic have low RBS. If you give them dextrose, if you give them dextrose, dextrose will utilize the thiamine, and patient can land into vernix encephalopathy. So if there is a patient of alcoholic, before giving before giving him dextrose, first replace with first give thiamine. Okay, everyone. So before you give dextrose to patient of alcoholic patient, you first give them thiamine, high doses of thiamine. You give them high doses of thiamine, and after giving thiamine, then give them dextrose. Because if you give them dextrose earlier, before giving thiamine, that dextrose will utilize thiamine, and patient can land into one encephalopathy. So patient shouldn't land into one encephalopathy. We will give first thiamine and then we will give dextrose. Everyone got this concept of alcoholic, because you will be sitting in your casualty and maximum time alcoholic patient will be coming to you who will be unresponsive. You first give them a thiamine and then dextrose. Okay, everyone, shall we move further? Okay. Now, someone was asking me, sir, is there any examination also to rule out the structural causes or metabolic causes of coma to differentiate between them? So there are structural causes of coma and there are metabolic causes of coma. So can we differentiate them on examination basis? Yeah, we can differentiate them. We all know that whenever we are going in medicine wards, maximum patient are CLD and CKD patient, maximum patient are alcoholic patient, and all they are suffering from CLD. And whenever they are in hepatic NCAL, we do a simple examination, that is your astraxis. You will tell patient to extend his arm. You will just give a flip. You will just give a flip on this finger, and there will be a tremor. There will be a tremors like this. These are known as your astraxis. It is your astraxis. So in metabolic coma, what you will find, there will be astraxis will be there. In metabolic coma patient, there will be astraxis. When you will tell patient to extend his arm, there will be a tremors. There will be a tremors like this. Okay, everyone. But can you find this aspects in structural causes of coma? No. Answer is no. Okay. So we have got this first concept that there can be aspexis. Aspexis generally present in metabolic causes of coma, not in structural causes of coma. Okay, sir. Next is your pupillary dilation. Next is your pupillary dilation. Pupillary dilation can be there. We all have studied in last lecture in raised ICP. In raised ICP, there is third nerve palsy और थर्ड नर्व पालसी क्या होगा? Pupillary dilation होगा. तो थर्ड नर्व में क्या हो रहा है? आपके क्या डैमेज हो रहा है? पैरासिम्पैथेटिक फाइबर डैमेज हो रहे हैं. तो क्या होगा? प्यूपल का डायलेशन. तो प्यूपल डायलेशन होगा. क्या मेटाबॉलिक कॉज में प्यूपल डायलेशन मिलेगा? नो. और क्या हो सकता है? अगर स्ट्रक्चरल कॉज ऑफ कोमा है, इट मींस ब्रेन इज डैमेज, एंड इफ ब्रेन इज डैमेज, देयर विल बी अ UMN findings. There will be a upper motor neuron findings, like there will be increase in tone, there will be increase in TTR, there will be contralateral weakness, there will be contralateral weakness. So in human findings, in structural cause of coma, what you can find, there will be no astraxis because astraxis is present in metabolic coma. Okay, sir. In structural cause of coma, there can be a pupillary dilation. You can find human findings here in structural cause of coma, like increase in tone, increase in DTR, contralateral weakness. Okay. Other thing, now we all know that in metabolic causes, it will be generalized. कैसा होगा? Generalized होगा और symmetrical होगा. Compared to the structural causes कैसे होते हैं? They are focal or they are asymmetrical. If suppose I have a human finding, so my contralateral side की क्या होगी? Weakness होगी, but other side क्या होगी मेरी? Other side will be normal. So your structural causes are focal and asymmetrical. Your metabolic causes are generalized and symmetrical. In structural causes of coma, asphyxia is not present, but pupillary dilation can be there, human findings can be there, and there can be absence of vestibulo-ocular reflex also in structural causes of coma. And what do you mean by vestibulo-ocular reflex? I have already told you in my lecture of dizziness and vertigo. In my lecture of dizziness and vertigo, I have told about vestibulo-ocular reflex in detail. But in this lecture, I will also just give you just glimpse about vestibulo-ocular reflex in few upcoming slides. Okay, beta? This how you can differentiate between structural causes of coma and metabolic causes of coma. Anyone doubt? Anyone having any doubt here? Just tell me. यहाँ तक सबको समझ में आ गया? Anyone? कोई doubt? Can now you differentiate between structural causes of coma and metabolic causes of coma on the basis of examination. Shall we go further? Just give me a thumbs up अगर यहाँ तक सबको समझ में आ गया तो. चलिए, shall we move further बेटा? Just tell me in comment section. Okay धीरज, okay आर्यन ना, अभी move. Now many times there is a question ना, student ask me, sir, ये when we give antihistamines and anticholinergics, that when we give antihistamine and anticholinergics. Good evening, Gautam, Krishna, Kumari. Today we are studying about coma. So when we give antihistamines or anticholinergics to patient feels drowsy or sleepy. Patient feels drowsy or sleepy. And why this happens? This happens because your reticular system, your reticular system and the fibers, the fibers in reticular system which projects to thalamus, the fibers in reticular activating system, they are cholinergics and histaminergic. Okay, so the fibers in the your reticular systems are cholinergic and histaminergic. That's why when you give antihistamines and anticholinergics to patient, his reticular system goes down, reticular system activity decreases, and patient feels sleepy. Okay, बेटा, चले आगे. चले बेटा आगे, यहाँ तक सबको समझ में आ गया बेटा? Shall we move further now? Okay. Now we will come to history taking. We will come to history taking of comatose patient. Comatose patient. Because in neurology, most important is your history taking skill. Is your history taking skill. So first question you will ask, onset. It is it is it a sudden onset? तो सडन ऑनसेट कहाँ कहाँ हो सकता है? हमारा सब एरेक्नोइड हेमरेज में, सब एरेक्नोइड हेमरेज में, या फिर सीजर में, या फिर सीजर में. So if there is a patient and his relatives and attendants are telling to you, no Rishali, no. So if there is a patient and his relatives are telling to you, sir, patient was all right few minutes back, but suddenly patient has went into coma, you will suspect subarachnoid hemorrhage or seizure. Okay. Then are your, if there is a history of fever, then what you will suspect? You will suspect meningitis, encephalitis, or any infectious disease. Third, if any focal signs, any focal signs are present or focal neurological deficiency is present, then you will suspect the structural causes of coma. ठीक है? Other, if there is a history of falls, there is a history of a fall, then you will suspect any kind of intercerebral hemorrhage, any kind of intercerebral hemorrhage. If there is confusion, if there is confusion, then you will suspect any kind of metabolic encephalopathy. Another, you will take history of any drug intake and history of trauma. ठीक है एवरीवन? तो हमें समझ में आ गया कि हिस्ट्री में हमें ऐसी क्या क्लिंज पॉइंट पूछनी है विच विल हेल्प अस टू मेक द डायग्नोसिस ऑफ द कोमेटोज पेशेंट. ठीक है एवरीवन? शैल वी प्रोसीड फर्दर? नाउ before we go to neurological examination coma patient, before we go to neurological examination coma patient, first we will see the about general examination. General examination. ठीक है? तो जनरल एग्जामिनेशन में क्या है? या नवीन, गुड. फर्स्ट इज योर heart rate. In heart rate, it can be a bradycardia. So, if there is a patient of coma and he or she is having bradycardia, what you will you suspect? Just tell me. If there is a patient of coma and his patient is having bradycardia, what you will suspect? Just tell me. Anyone? Vishali, Aryana, Naveen. आपके पास पेशेंट आया कोमा का एंड पेशेंट को ब्रेडिकार्डिया चल रहा है, क्या सस्पेक्ट करेंगे हम? Raised ICP, very good, Dheeraj. We all know last class we have studied na raised ICP, Cushing reflex, in which there is a hypertension and bradycardia. Why Rishali, Aryan, and Naveen, you are not able to answer this question? In last class we have studied na Cushing reflex, hypertension, bradycardia. So we will suspect first important thing that is your raised ICP. Then any drug intoxications or any kind of heart disease. Okay. Next is your tachycardia. When you will get tachycardia, suppose there is a patient with meningitis, encephalitis, patient is having infection. So patient is having infection, there will be fever, and fever in fever generally we have tachycardia. So infections. Okay. Other than heart rate is your blood pressure. In blood pressure, first is your hypertension. So a patient of coma having hypertension, what will you suspect? Patient of raised ICP having hypertension, Rishali, Dheeraj, anyone other than Naveen? Anyone can answer? Aryanag, Rishali, it is your raised ICP. Okay, but Rishali, but in current scenario, I haven't seen such thing like that. Nah, I haven't seen such thing like that. So I can't comment on these things. Most probably, it is tough to treat patient from this therapy. But if there is some way, if you are telling, then it is good. But right now, I haven't seen any case such that like. Okay, better Rishali. So hypertension can be due to raised ICP, and as he telling, due to intracranial hemorrhage, it can be there. ठीक है? So can anyone tell me why there is bleed in hypertension? Why there is bleed in hypertension? Why there is bleed in hypertension, and which areas of brain generally bleed when there is hypertension? Which areas of your brain generally bleed when you are having hypertensive bleed? Anyone? which is the most common site of hypertensive bleed in your brain? Your NEETPG MCQ. Anyone? Naveen, Dheeraj, most basal ganglia. Very good. It is your thalamus, your pons, putamen. Can anyone tell me why only these parts bleed in hypertension? Why only these parts bleed in hypertension? Why other part doesn't bleed? What these parts are having something special in them that suggests that they always bleed in hypertension? Can anyone tell me इन पार्ट में ऐसा क्या स्पेशल है कि ब्लीड करते हैं हाइपरटेंशन के अंदर? These parts are having and arteries and arteries. That's why they bleed. Okay. After hypertension is your hypotension, and hypertension can happen when there is a patient of MI or barbiturates और अल्कोहल. बेटा क्योंकि इनमें एंड आर्टरीज है ना. सपोज दिस इज योर आर्टरी एंड दिस इज अदर एंड देन further more small, and suppose this is your basal ganglia, so these are your end arteries. Okay, so they end arteries have more chances of getting bleed in hypertensive cases. That's why basal ganglia generally bleed when there is your hypertensive bleed. Okay, Rishali beta. So MI, barbiturates, alcohol, intoxication. So these all are findings when you do a general physical examination. Okay, beta. Now we will come to third is your respiration. Okay, Dheeraj. So, in general physical examination, first you will check his heart rate. If there is a bradycardia, then it can be due to a raised ICP, drug intoxication, or heart disease. Because we all know that raised ICP present to us as hypertension and bradycardia. When there is tachycardia generally happens in fever. So if there are cases like meningitis, encephalitis, where there is infection, so due to fever, patient can have tachycardia. Then comes BP. BP, it can be hypotension or hypotension. Hypertension generally due to raised ICP or intracranial hemorrhage. And generally bleed happens in which area? Thalamus, pons or putamen, because they are having end arteries there. Then comes your hypotension. How can be hypertension be there? Due to MI, barbiturates or alcohol intoxication. Okay, Dheeraj. Then comes your respiration. So in respiration, first is your breath. First is your breath order. So, can anyone tell me what is the breath order in DK patient? DK patient में कैसी breath आती है? Anyone? Breath order in DK patient. Anyone can tell me what kind of breath order we expect? Very good, Dheeraj. Fruity or sweet smell like acetone. Fruity. Very good, beta. Yeah, ketotic smell. Then comes your arsenic poisoning. Now, can anyone tell me what kind of smell do you get in arsenic poisoning? Anyone? This is your garlic order. Okay. Very good, Vishali. Very good, beta. Very good, Naveen. Garlic order. Very good. Then comes your patient. In respiration examination, you have checked breath order. Then you will check hyperventilation. Is patient hyperventilating or not? What all are the causes of hyperventilation? It is your acidosis and sepsis. Then is your hypoventilation. In hypoventilation, causes are your mixed edema, coma. Okay. Now we will come to the pattern of respiration. So can anyone tell me, in last lecture of raised ICP, I have told you the pattern in raised ICP patient. Which kind of pattern you get in raised ICP? Because but in Vishali mixed edema patient, your respiratory rate reduces because your there is a paralysis of respiratory muscles are there, so patient can't ventilate properly. Can anyone tell me the pattern of respiration in raised ICP patient? We have studied in last lecture. रेज्ड आईसीपी पेशेंट में रेस्पिरेशन पैटर्न कैसा होता है? वेरी गुड, वेरी गुड हर्षिता. इट इज काइन स्टोक्स ब्रीदिंग. और ये कैसी ब्रीदिंग होती है? हाइपोवेंटिलेशन, देन एपनिया, देन हाइपरवेंटिलेशन, एंड देन सेम साइकिल ऑफ हाइपोवेंटिलेशन, एपनिया, देन हाइपरवेंटिलेशन. ठीक है. हाइपरवेंटिलेशन क्यों होता है? क्योंकि फर्स्ट इज योर हाइपो, देन आफ्टर there is apnea, and due to apnea there is rise in PCO2, and PCO2 is a powerful stimulator of respiratory center, so it will lead to hyperventilation. Yeah, Naveen. Okay, so if there is damage to cortex, you will get a kind of type of breathing. If damage is to your midbrain, damage is to midbrain, then pattern of breathing is known as central neurogenic neurogenic central neurogenic hyperventilation. Central neurogenic hyperventilation, that is your CNH. Okay. If there is damage to your pons, yeah, Naveen, if the damage to is your pons, then there will be a apneostic breathing. Apneostic breathing. और apneostic breathing कैसे होती है? See, there will be a deep inspiration, then pause, then expiration. So deep inspiration, pause, and then normal expiration. See again, deep inspiration, pause, देन अ नॉर्मल एक्सपिरेशन. ठीक है. तो क्या होगा इसमें आपका? डीप इंस्पिरेशन, डीप इंस्पिरेशन, देन अ पॉज, देन एक्सपिरेशन. ठीक है. एप्निस्टिक ब्रीदिंग पैटर्न सबको समझ में आ गया. अब अगला है हमारा मेड्यूला. क्या है हमारा अगला? मेड्यूला. एंड मेड्यूला में कैसी टाइप की ब्रीदिंग होती है? हमने कल लास्ट लेक्चर में पढ़ा था. इट इज ना बायोट्स ब्रीदिंग. ये कैसी ब्रीदिंग होती है? इट इज इन ए इरेगुलर टाइप ऑफ ब्रीदिंग. So if there is a patient who is having irregular breathing pattern, you should always suspect the patient to be of coma. You always suspect that patient to be coma. Yeah, very good, Naveen. Because when there is herniation, first midbrain will be affected, then pons will be affected, then medulla will be affected. So initially there will be a when the cortex is affected, there will be a Kinstokes type of breathing, and later on Biot's breathing, which is a irregular type of breathing. ठीक है everyone. सो कैन यू प्रोसीड फर्दर? सबको समझ में आ गया पैटर्न्स ऑफ ब्रीदिंग? Yeah, Dishali, you are right. Yeah, thanks, beta. Uh, from where do you study these kinds of things, Dishali? So next is our, so we have done our basic examination. So we have done basic examination of, that is your BP, hypertension, hypotension, then your respiration order, hyper and hypoventilation. Then we have done patterns of respiration. Now we will come to the temperature. Now we'll come to the temperature. Okay. In temperature, if there is fever, if there is fever, what you will suspect? You will suspect either a subarachnoid hemorrhage, either a infection like meningitis or encephalitis, or heat stroke, or heat stroke, or inflammation, or inflammation. Okay, everyone. Then after fever is your hypothermia. In hypothermia, what you will suspect? You will suspect sepsis, shock, mixed edema, coma, any drug intoxication, any drug intoxication, like your barbiturates, like your barbiturates. Yeah, Naveen, infection like meningitis or encephalitis. ठीक है everyone? Shall we move further? So Dheeraj is asking how subarachnoid hemorrhage leads to hyperthermia. Dheeraj, you can study this in the. I have a lecture also on fever. I I have a recorded lecture in of fever. In this, that you can study the subarachnoid hemorrhage mechanism of hyperthermia. Because if I will explain in this class, now the class will be too long. ठीक है बेटा धीरज? Okay, Rishali and okay, Harshita, Priyanka, don't fight. And Dheeraj, you can study this in the lecture of my fever recorded lecture. Okay, beta. After this, we have seen temperature. Now we will come to the, now we'll come to the fundus examination. So can anyone tell me what you will found in the fundus examination? आई एग्जामिनेशन में हमें क्या मिलेगा? Anyone? Fundus examination. So anyone can tell me आई एग्जाम कोमेटोस पेशेंट की आई एग्जामिनेशन में क्या क्या फाइंडिंग मिल सकती है? Anyone? We can find out papillary edema. It is in raised ICP. Okay, everyone, got this? On fundus examination, papillary edema can be there. ठीक है एवरीवन? फंड एग्जामिनेशन में क्या मिलेगा? पेप्लिडेमा. व्हाई? ड्यू टू रेज आईसीपी. या बेटा नहीं? ठीक है. अदर फाइंडिंग, देयर कैन बी डायबिटिक रेटिनोपैथी. डायबिटिक रेटिनोपैथी. If patient is of diabetes mellitus or patient has land into decay, so on eye examination you can get diabetic retinopathy also. Other thing, there can be hemorrhage. There can be hemorrhages on retina due to subarachnoid hemorrhage or subhyaloid hemorrhage. Yeah, Naveen, you're right. ठीक है. So these all things you can find in your fundus examination. या नवीन? या नवीन, या you are right. So we have covered a history part of comatose patient. Okay, now before we come to now we will come to the most important thing of our class, that is neurological, that is neurological examination of comatose patient of, या नवीन, neurological examination of coma patient. ठीक है? So what many times I've seen na, doctors think that patient is in coma, there is no there is no use of doing neurological examination. But there is the importance of doing neurological examination in coma patient, and that we will study in this lecture. That how should we do the neurological examination? So starting with neurological examination, everyone be attentive now, because we will deal with the most important part of our lecture, that is the neurological examination of coma patient. So first, starting with a patient come to you of coma. पेशेंट हमारे पास आया कोमा का, सबसे पहले हम क्या करेंगे? अराउजल। पेशेंट को हम पेन स्टिमुलस देंगे, क्या पेशेंट जग पा रहा है, नहीं जग पा रहा? तो फर्स्ट देयर विल बी, वी विल डू अराउजल. एंड हाउ वी विल डू अराउजल? वी विल डू बाय tickling the nostrils with a cotton wisp. Okay, or we can do one thing more, we can put pressure on bony prominences. ठीक है, तो हम क्या करेंगे? पेशेंट हमारे पास आया, हम अराउजल करने की कोशिश करेंगे, या तो हम जो ब्रोमी प्रोमिनेंस है वहां पे पेन अप्लाई करेंगे, या हम उसकी स्टर्नम को रब करके देखेंगे क्या पेशेंट का अराउजल हो पा रहा है. एंड अगर पेशेंट का अराउजल हो पा रहा है, इसका मतलब पेशेंट वाज इन लाइट कोमा, पेशेंट वाज इन अर्ली स्टेजेस ऑफ कोमा. ओके एवरीवन? या फर्स्ट इज योर जीसीएस, first and most important is your GCS. After that, we will do arousal either by tickling the nostril with any cotton wisp, or we will put pressure on bony prominences. ठीक है? This is the first important step. After this, we will ask a question to ourselves. We will ask a question to ourselves. What question we will ask? We will ask, we have to localize. So either it is a bilateral cerebral hemisphere issue, or is it a RAS issue, or it is due to any focal damage to brain, any focal damage to brain which is having some focal neurological deficits. So we have to ask these three questions to ourselves. ठीक है? सो आर मेन एम इज टू फाइंड कि भाई कि कोई बायडल सेलुलर हेमिस्फीयर डैमेज है, कोई रास इशू है, बिकॉज here we are doing neurological examination, and if we are doing neurological examination it means that we have ruled out all the reversible and metabolic causes. तो अब हम अराउजल करके देखेंगे अराउज हो रहा है नहीं हो रहा. अगर ये भी अराउज नहीं हो रहा नॉर्मल टेक्निक से, वी विल थिंक कि ये इज देयर अ बाइलेटरल सेरिब्रल हेमिस्फीयर इशू और रास इशू, और देयर अ फोकल डैमेज टू ब्रेन लीडिंग टू एनी फोकल न्यूरोलॉजिकल डेफिशिएंट. And before we proceed to the examination part, what we will do? We will first expose the patient. We will first expose the patient limbs. हम क्या करेंगे? पेशेंट के लिम्स एक्सपोज करेंगे. व्हाई वी आर एक्सपोजिंग पेशेंट लिम्स? बिकॉज इन लास्ट लेक्चर वी हैव स्टडीड that in raised ICP patient there can be a two types of rigidity, decerebrate and decorticate rigidity. And if we do a pain stimulation, especially in a supraorbital ridge, suppose if I am a patient with raised ICP and you are doing a pain stimulation, and if I am suffering from a decorticate positioning, so my hands will get flexed, my hand will get flexed, because we all know the decorticate there is a flexion of upper limb and extension of lower limb. So we first should expose all the limbs of patient. ओके नवीन रिशाली, डिसेरिब्रेट रिजिडिटी में क्या होता है? एक्सटेंशन ऑफ अपर लिम्ब, एक्सटेंशन ऑफ लोअर लिम्ब. सो वी फर्स्ट expose all the patient limbs to check out the posturing part. Why are we doing? To check the posturing. Then we will cut off all the sedatives. We will cut off all the sedatives. All the sedative drugs we were using, we will cut off them such that we can do a proper neurological examination. And why are we doing the examination? Because we have to found the we have to found the etiology. हमें क्या चाहिए? हमको etiology चाहिए पेशेंट की कि क्या etiology है पेशेंट की, कि what all are the reasons behind the coma, what all are the reasons behind the coma. ठीक है एवरीवन? So first we will begin with the examination. We are doing here neurological examination. So first thing we will do is the first. So we will do a light reflex. We will do a light reflex to check is the if is the pupil is responsive to light or not. Response of response of pupil to light, and your light reflex is mediated by which cranial nerves? Cranial nerves 2 and 3, because your third nerve originates from midbrain, third and fourth originates from midbrain. So first we will do a light reflex. If patient responsiveness, we will check responsiveness of pupil to light, and in these patients light reflex generally will be absent. Okay everyone, got this concept? First we will do a light reflex examination. We will take a torch and we will do a light examination on pupil. Okay everyone? Then after doing light reflex, we will do so after doing light reflex, but we will do other reflex. That is your corneal reflex. Yeah, Nami. That is your corneal reflex, in which we will check the blinking of eye. It is mediated by the fifth and seventh nerve. Either we can do it by a cotton wisp or by putting a normal saline. So if Yeah, Naveen. So if see this how we do a corneal reflex. So if corneal reflex is present, it means 5 and 7, because 5 and 7 originate from your pons, and seven generally 5 and 7 originate from your pons. So we are checking here the for pons. So all these are which we are studying. These are your brainstem reflexes. These are your brainstem reflexes. So first we will do light reflex to check the response of pupil to light. After that, we will do a corneal reflex. And if there is this is a patient in which there is a brainstem death patient, so corneal reflex will be absent. Corneal reflex will be absent. Everyone has got this till now. Just give me a thumbs up. Just give me a thumbs up if you have understood till now. Everyone, सबको समझ में आ गया कॉर्नियल और लाइट रिफ्लेक्स? जस्ट गिव मी अ थम्स अप. ओके अर्शिता, ठीक है. सो वी हैव डन विद द ओके. सो वी हैव डन विद द दिस रिफ्लेक्स. सो नाउ there is a other reflex, that is your oculocephalic. Okay, Dheeraj. Oculocephalic reflex. That is your vestibulo-ocular reflex. Okay, and this is done with the help of cranial nerve third, sixth, and eighth. ठीक है? Also known as doll's eye reflex. ठीक है? तो can in my last lecture on which is on dizziness and vertigo, I have told about vestibulo-ocular reflex there. So can anyone tell me what do you mean by vestibulo-ocular reflex? Just anyone can tell me what do you mean by vestibulo-ocular reflex? Just tell me. Anyone? What do you mean by vestibulo-ocular reflex? Because in last lecture we have done and gone with this reflex, vestibulo-ocular reflex. It is a very important reflex of your brainstem region because it involves third, sixth, and eighth nerve. Can anyone tell me about vestibulo-ocular reflex? I have told you in my last lecture dizziness and vertigo. So see, if you are not knowing that, then I will tell you again. Okay, Dheeraj. And eye movements are opposite to the side of rotation. See, if anyone wants to know further more about vestibulo-ocular reflex, he or she can go to my lecture on dizziness and vertigo. In here, I will shortly tell you about that reflex. See, these are your eyes. Suppose this is your right and this is your left, and this is your eye. Okay, and this is the partition. These are your small, beautiful eyes. Is there is some issue with sound? Sound is not coming properly. If sound is okay, just give me a thumbs up, Dheeraj. Is am I audible? Aryan, Nag, Rishali, Naveen, just give me thumbs up if I am audible. Just give me a thumbs up if I am audible. Everyone, am I audible? Dheeraj, Naveen, just give me a thumbs up if I am audible. Okay, yeah. So, see, there is your this nuclei. That is your third nerve. It is your third nerve nuclei. Okay, sir. Then below here is your C is your sixth nerve nuclei. ठीक है? Okay, sir. Now we all know that the sixth nerve abducer nuclei and third nerve nuclei are connected with each other. They are connected with each other with a special type of fiber. With a special type of fiber, and this fiber is your MLF. That is your medial longitudinal fasciculus. Okay, sir. Now, pons. Now, in sixth nerve nucleus present in pons. In pons, there is a special type of nuclei. In pons, there is a special type of nuclei. That is your PPRF. That is your PPRF. Okay, and this PPRF have connection with the sixth nerve nuclei. ठीक है? Done, everyone? ठीक है, तो सबको ये डायग्राम समझ में आ गया कि देयर इज थर्ड नर्व, देन देयर इज सिक्स्थ नर्व न्यूक्लियस एंड पीपीआरएफ. राइट साइड, लेफ्ट साइड. योर थर्ड नर्व न्यूक्लियस एंड sixth nerve nucleus are connected with each other with the help of MLF, and this whole structure, the sixth nerve nucleus present in pons. एंड इन पॉन्स इज योर पीपीआरएफ. पॉन्स में क्या है हमारा? पीपीआरएफ न्यूक्लियस है. ओके सर, वी गॉट दिस. नाउ सपोज if there is a patient, if there is a patient and I am rotating his head to right side, I am rotating his head to right side. ठीक है? If I will rotate his head to right side, I have told in my previous lecture that endo lymph due to inertia, due to inertia will move to left, will move to left. Okay, and it will stimulate this eighth nerve nuclei, this eighth nerve nuclei on right side, and this eighth nerve nuclei then it will stimulate the PPRF nucleus of opposite side. PPRF nucleus of opposite side. So if I am moving my head to right side, if I am moving my head to right side, my endolymph will move to left side. And this when this endolymph move to left side, there is increase in action potential and it stimulates the same side vestibular nuclei. So if I am moving my head to right, due to movement of endolymph to left side, there is generation of action potential, and this action potential it is leading to stimulation of the eight term nuclei on the right side. ठीक है एवरीवन, गॉट दिस कि भाई राइट साइड का एक न्यूक्लियस स्टिमुलेट होगा. ये एक नव का न्यूक्लियस जो राइट साइड का ये आपके लेफ्ट साइड की पीपीआरएफ को क्या करेगा? स्टिमुलेट करेगा. ओके सर, लेफ्ट साइड का पीपीआरएफ इट विल स्टिमुलेट लेफ्ट साइड सिक्स नंबर न्यूक्लियाई, and this left side spectrum nuclei, what it will do? It has its connection on the left side LR, lateral rectus. Okay, and it has also connection with other side third nerve nuclei with the help of MLF. And this third nerve nuclei, what it will do? It will do MR, medial rectus. So when I am moving my head to right side, when I am moving my head to right side, due to stimulation of sixth nerve nucleus on left side and due to stimulation of third nerve nucleus on right side, my eyes, if my LR is stimulated, my eyes will go in this direction, and here my eyes will go in this direction. So when I am moving my head to right side, my eyes will move to left side. Everyone got this concept? That when my eyes will move to right side, when my head will move to right side, my eyes will move to left side. Suppose this is a pen, and if I want to fixate my eyes on this pen, and if someone calls me from right side, I am moving to right side, but I still want to see this pen. So I will fixate my eye. And how will my eye will fixate? When I am moving my head to right side, my eyes are going to left side. So if you are moving in your head in one direction, your eyes will go to opposite direction. That is your vestibulo-ocular reflex, which is present when your brain stem is normal. किसी को कोई डाउट? जस्ट टेल मी कमेंट सेक्शन. अगर मैं राइट साइड की तरफ अपना फेस करूंगा, रोटेट करूंगा, तो मेरा एट नर्व स्टिमुलेट होगा. माय एट नर्व विल स्टिमुलेट, एट नर्व स्टिमुलेट अदर साइड पीपीआरएफ, other side PPRF will stimulate sixth nerve nuclei of other side, and this sixth nerve nuclei will stimulate the LR of left side, and this sixth nerve nuclei also has connection with right side third nerve nuclei through MLF, and then this third nerve nucleus will stimulate its MR. So when I am moving my head to right side, my eyes are going to left side. This is your vestibulo-ocular reflex. Everyone got this? Just tell me. Vishali, Dheeraj, Dheeraj, Arya, got this? That what is your vestibulocular reflex? That when you move your head to right side, when you move your head to right side head rotation, your eyes will go to left side. Okay, now see this. Now see this patient. In this patient, the brainstem was intact. Brainstem क्या थी? Intact थी. So when he is moving his head to right side, eyes कहाँ जा रही है? Eyes जा रही है left side. And when he is moving his head to left side, eyes किधर जा रही है? Eyes right side जा रही है. So eyes are going in opposite direction. Eyes goes in opposite direction of head rotation. ठीक है. So now you should tell me, if there is a patient of brainstem death, if there is a patient whose brainstem is injured, so if you move his head to right side, will his eyes should move to left side or not? Just tell me. Naveen, you are asking me how endolymph is helping. Due to movement of endolymph, due to movement of endolymph, there is generation of action potential. There is a generation of action potential, and you can study about this in my lecture of dizziness and vertigo, where I clearly mention how this whole mechanism works. Okay, how this endolymph stimulates. So in my that lecture, you can study about this. Okay, Naveen. So just tell me, if there is a patient whose brainstem is not intact, whose brainstem is damaged, so when he will move his eyes to right side, in which direction his eyes will go? Just tell me in comment section. If there is a patient whose brainstem is damaged, if suppose my brainstem is damaged and I am moving my head to right side, where will my eyes will go? Same side. Very good, Dheeraj. This is known as this is known this phenomena is present in the patient who are having brainstem death. In these kinds of patients, vestibulocular reflex are absent. Dorsal reflex are absent. See, this patient, his brainstem was not intact. Brainstem was not intact. So head is going to right. His eyes are also going to right. And head is going to left. His eyes are also going to left. Okay. So suppose in there is in you are doing a round in your ward in your emergency, and someone suspecting that this patient may be in coma due to brainstem death. What you will do? You will open his eyes and you will rotate his face to one side. So you are rotating his face to right side, and his eyes are going to same side. This is the beauty of neurology. If you study properly, if you take history properly, and if you do a proper examination, just with the help of 1 or 2 minutes, you will get to the diagnosis. Okay, everyone. Now everyone got this concept. If there is a patient of brainstem death, if there is a patient of brain stem death, vestibulo-ocular reflex will be absent, and eyes will eyes will move to same side. ठीक है एवरीवन. जस्ट गिव मी थम्स अप अगर ये कंसेप्ट सबको समझ में आ गया तो. वेरी गुड. एंड बिफोर एंड बिफोर एंड बिफोर यू आर डूइंग and before you are doing this vestibulo-ocular reflex mechanism or maneuver, you must you must rule out cervical spine injury. So you must do a X-ray, and on X-ray you must rule out cervical spine injury, because if you are doing this method of cervical spine injury, more damage will be there. Okay, everyone. Okay, very good. So we have here, we will revise all the neurological examination. So first, what we understand that we should expose the limb for caution. We will do all the reflexes related to brainstem. That is your light reflex, inlet nerve 2 or 3. We will do corneal reflex for fifth and seventh nerve by touching the cornea with the help of cotton whisk or normal saline. Or we can do the most important reflex, that is the vestibulo-ocular reflex, which is mediated by third, sixth, and eighth cranial nerve. That is, when normal patient, when brainstem is intact and you move your head to right side, your eyes will go to left side. But if there is a damage to patient of there is a damage to brainstem, when you rotate your head to right side, eyes will also go to same side. Okay. Now we will come to other movements. So other ocular movements. Other ocular movements. Now, in my last lecture, I have told you that when we come to the horizontal movements, when we come to horizontal movement, there are three types of horizontal movement. That is, first is your first are your saccades. What are saccades? Can anyone tell me what are saccades? Suppose I am sitting here quietly and suddenly someone comes. Suppose I am sitting here and suddenly some beautiful gums comes from my right side. My eyes will just pop up. Immediately my eyes will shift to right side. These are your saccades. When you suddenly see some object, your eyes will pop to other side. That is your saccadic movement. Okay, everyone. Suppose I am sitting here and a beautiful girl is coming. So what I will do? I will try to see that beautiful girl. So my eye will directly move to right side. So this sudden jumping of eye, this sudden saccadic movements of eye and horizontal side, these are known as your saccades. Other are your pursuit, and other third was your vestibulo-ocular reflex. या धीरज, अगर कोई सुंदर लड़की आ रही है तो हम उसको देखेंगे, ठीक है. Third is your vestibulo-ocular reflex, that when you are seeing some object, suppose suppose this suppose a beautiful girl is sitting in front of me and someone calls me from right side. So I am rotating my head to right side, but I still want to see that beautiful girl. So my eyes will go to left. This is my vestibulocular reflex. So vestibulocular reflex works when I am moving my head and I want to see some object. But when there are saccadic pursuit movements are there, when some object is moving and I don't want to move my head and I suddenly want to see that object, so my saccadic and pursuit will see it. Saccadics are rapid movement and pursuit are slow. So we have understood about vestibulocular reflex. Now, other movement. There is a saying in neurology, we generally say that eyes, eyes look towards a hemispheric, eyes look towards a Rishali is asking, Park cerebri का क्या फंक्शन होता है? बेटा, in last lecture I have told you about tentorium cerebri. Park cerebri क्या है? It is a sheet of a dura matter. एक शीट है. ये शीट क्या करती है? ब्रेन को दो पार्ट में डिवाइड करती है. One is your right cerebral hemisphere, other is your left cerebral hemisphere. This is your Park cerebri function. Okay, Rishali. So I look towards a hemispheric lesion and away from a brainstem lesion. ठीक है? क्या मतलब है? This is the one of the important concepts in neurology. They are saying that when there is some lesion in your hemisphere, eyes will look eyes will look at that lesion. मतलब suppose if I am having a right stroke, so my eyes will move towards right. My eyes will move towards right. And when I am having a brainstem lesion, my eyes will shift towards left. Okay. So this is a saying in neurology that eye looks towards a site of hemispheric lesion and they looks away from a brainstem lesion. Okay. So now we will understand why this mechanism happens. So see, we all know that these are what these are. These are the beautiful eyes. These are the beautiful eyes of a beautiful girl. Okay, everyone. Okay, sir. These are the beautiful eyes of a beautiful girl. Now, here is your third nerve nucleus. Okay, sir. These are third of nucleus. Then below are these are your sixth nerve nucleus. And sixth nerve nucleus is connected with third nerve nucleus with the help of, just tell me in comment section, with the help of which tracks sixth nerve and third nerve nucleus are connected with each other. Can anyone tell me in comment section? Sixth nerve nuclei and third nerve nuclei are connected with which thing? Just Rishali, Dhiraj, Naveen, MLF. Very good. So it is your MLF. Okay, I am drawing. ठीक है. This is your MLF. Okay, Rishali. Okay, okay, beta. ठीक है. So see, these are the eyes of a beautiful girl. Okay, sir. First is your third nerve nucleus that is in your midbrain. Then in pons is your sixth nerve nuclei. Okay, okay, everyone. Till now, you understood about this concept. Now we all know that in pons there is six nerve nuclei. Okay, and here are the PPRF nuclei also in pons. In pons, here are PPRF nuclei. This PPRF nuclei stands for para, median, pontine, reticular formation. ठीक है. तो ये डायग्राम सबको समझ में आ गया. एंड पीपीआरएफ क्या करता है? पीपीआरएफ सेम साइड के सिक्स नंबर न्यूक्लियस से क्या करता है? अटैच. ठीक है. ओके. तो ये डायग्राम सबको समझ में आ गया यहां तक? एवरीवन क्लियर विद दैट देयर इज थर्ड नर्व न्यूक्लियाई, सिक्स नर्व न्यूक्लियाई एंड पीपीआरएफ. पीपीआरएफ connects with sixth nerve nuclei. Sixth nerve nuclei connects with opposite side third nerve nuclei with the help of MLF. ठीक है एवरीवन, समझ में आ गया सबको ये? शैल वी गो फर्दर? ठीक है सर, ये समझ. ठीक है, समझ में आ गया. ओके. ठीक है. अब ये है हमारा सबसे ऊपर सेरिबल कॉर्टेक्स. क्या है हमारा? सेरिबल कॉर्टेक्स. सेरिबल सेरिबल कॉर्टेक्स. एंड यहाँ पे प्रेजेंट होता है फ्रंटल आईफील्ड एरिया. व्हाट इज प्रेजेंट हियर? फ्रंटल आईफील्ड एरिया नंबर 8. इट इज प्रेजेंट इन frontal lobe. Now, function of this FEF, function of this frontal eye field area is to look to opposite side. FEF function as to look to opposite side. So, right frontal eye field will help you to look to left side. Will help to you to look to left side. So, suppose if my right frontal eye field helps us to look to opposite side, then now see your what. Suppose if I am stimulating your PPR, if I am stimulating your PPR, what it will do? It will stimulate sixth nerve. Okay, sir. This sixth nerve will stimulate this LR. Okay, sir. And this sixth nerve will stimulate third nerve MR. So eyes will go to left side. So if left PPRF, if left PPRF stimulated, eyes goes to लेफ्ट साइड। सबको ये बात क्लियर है? एवरीवन गॉट दिस concept? If I will be stimulating my left PPRF, my eyes will be going to left side. Everyone got this concept? Just give me a thumbs up. Naveen, Vishali, Dhiraj, सबको समझ में आया? If my eyes will go to left side, if my left PPRF is stimulated, my eyes will go to left side. It means if P- left PPRF stimulated, eyes will go to that side. ठीक है धीरज, ओके, समझ में आ गया? वेरी गुड। अदर कंसेप्ट, I have told you that FEF has to look to opposite side. So what FEF does, that FEF, it stimulates it stimulates contralateral PPRF. It stimulates contralateral PPRF. So suppose if I wants to look to my left side, if suppose I am sitting here and I want to look to my left side. For looking to my left side, which should be stimulated? My left PPR should be stimulated. And who will stimulate my left PPR? Either left PPRF can stimulate it by itself, or my right frontal eye field, because my right frontal eye field have contralateral connection to left side PPRF. So if my right frontal eye field is stimulated, it will stimulate left side PPRF. I will look to left side. Or if my left PPRF is stimulated, I will look to left side. Okay, everyone? Okay. So looking to left side, for looking to left side, either my left PPRF should be stimulated, or my right frontal eye field should be stimulated. These are known as your horizontal conjugate eye movements. ठीक है? And I have told you that if I looks towards a site of hemispheric lesion and away from a brainstem region, now we will understand. Now suppose if I am having pathology of right frontal eye field, I am having pathology of right frontal eye field. So can I look to my left side? No, because my left PPR will not be now stimulated. So if I am having pathology of right frontal eye field, my eyes will go towards right side. First, if there is damage to cerebral hemisphere, okay, and if there is damage to brainstem, if there is damage to brainstem, suppose my my left PPRF is damaged. So can I look to my left side? No, because left PPR helps us to look to left side. So if my left PPRF is damaged, my left pons is damaged, can I look to my left side? No. So my eyes will go to right side. That is contralateral side. सबको समझ में आ गया ये? सबको एक कंसेप्ट समझ में आ गया कि if there is a there is see, I will tell you again. See this diagram again. There are three nucleus: third nucleus, sixth nucleus, and there is PPRF. Okay, your sixth nerve and third nerve have connection with the help of MLF. Okay, sir. Now suppose if my left PPRF is stimulated, it will stimulate left sixth nerve nucleus, which result in left LR, and LR will go to left side. Okay, and left sixth nerve will stimulate contralateral third nerve, that is right side third nerve, which will stimulate right side MR. So my eye will go to left side. So left PPRF helps us to look to left side. So if left PPRF is damaged, my eyes will go to contralateral side. That's why in brainstem injury, eyes goes to opposite side. Okay, sir. Now we all know that our PPRF is also stimulated by right hemisphere. So if right frontal eye field is stimulated, that is area number 8, it will stimulate contralateral PPR. It will stimulate contralateral PPR. So if I want to look to my left side, my right frontal eye field will stimulate my left PPRF, and my left PPRF will, what will it do? It will do, eyes will go to left side. So if right frontal eye field is damaged, can it stimulate my left PPRF? No, sir, it can't stimulate your left PPRF. So my eye will go to right side. So in cerebral hemisphere lesion or frontal eye field lesion, eyes will go towards the site of lesion. But in brainstem, that is the left PPR vision, eyes will go opposite to the site of lesion. सबको समझ में आ गया? Just tell me. PPRF helps us to look on the same side. Frontal eye field helps us to look to opposite side by stimulating contralateral PPRA. Very good. अगर सब समझ में आ गया तो किसी को any having any doubt, just tell me in comment section. I will repeat again. See this diagram. This is your frontal eye field area. This is your frontal eye field area number 8, which helps us to look to opposite side. And see this diagram. This is your left frontal eye field area. This is your left frontal eye field area, and left will stimulate contralateral PPRF. So left will stimulate right PPRF. Okay, sir. Right PPRF will stimulate right sixth nerve, and right sixth nerve will go to right LRC, and right sixth nerve will also, with the help of MLF, will stimulate contralateral third nerve, that is left third nerve, and both eyes will go to right side. So left frontal eye field stimulated, right PPRF stimulated, and right PPRF will, what it will do? It will make eyes go to same side. So eyes will go to right side. Anyone till now? Any doubt? If all of you have understood till right now, just give me thumbs up. Then we will move further. Okay, Naveen, I will tell you again. So Naveen, tell me in which connection you are confused. In which connection you are confused, Naveen? Just tell me. I will clear that again. Naveen, tell me in which connections you are confused. Just tell me. Okay, see, I will draw a diagram again. See, if this is your right side, this is your left side. We are drawing one line. Okay, sir. First, we will draw third nerve nucleus. Okay, sir. Then we will draw sixth nerve nucleus. Sixth nerve. Okay. Then we will draw PPRF nucleus. समझ में आ गया? आ गया, ठीक है. PPRF अपने सेम साइड के सिक्स नर्व को स्टिमुलेट करेगा, एंड सिक्स नर्व अपोजिट साइड के थर्ड न्यूक्लियस को स्टिमुलेट करेगी विद द हेल्प ऑफ MLF. ये क्या है? MLF. ठीक है. Now, if left PPRF is stimulated, it will stimulate left sixth nerve, and left sixth nerve will stimulate left eye, LR6. So I will go to left side, and sixth nerve also will stimulate MLF. So right third nerve nucleus will stimulate, right MR will there. So when left PPRF is stimulated, both eyes will go to left side. So left PPRF can be stimulated by itself also, or by with the help of opposite frontal eye field area. So pathway is same both in vestibulocular reflex, both in frontal eye field, but mechanism is different. In vestibulocular reflex, your movement of head was stimulating PPRF. Your movement of head was stimulating PPRF there. But in horizontal conjugate movements, your second and pursuit, your right frontal eye field is stimulating PPRF. So basic path of eye is same everywhere. Okay, Naveen, Dheeraj, Rishali, give me thumbs up. Then we will proceed further now. If you have all got this concept, just tell me. Shall we proceed further? Anyone having any doubt, just tell me right now in comment section. Or we will move further. Okay, Harshita, okay. Dheeraj, okay. Naveen, are you okay? Should we move further? Naveen, have you got the concept? सबको समझ में आ गया आज? कैसे कौन सी कॉन्जुगेट मूवमेंट्स किस लेवल पे क्या होती है? ओके आर्यना. नाउ अब in brainstem is your midbrain, pons, medulla. So we have tested all nerve third, sixth, seventh, eighth, ninth. Now we will test the 9th, 10th, 11th, 12th cranial nerve. So how we can test that? There is one thing known as your gag reflex. There is one thing known as your gag reflex, and other is your, so gag reflex is mediated by cranial nerve 9th and 10th. ninth and 10th of medulla. Okay. So how gag reflex is done? See, you are seeing this patient. Okay, sir. First, you will put a tongue blade inside your mouth and you will press the tongue such that a space is there such that you can stimulate the posterior pharyngeal wall. You can stimulate the posterior pharyngeal wall. So you are seeing here this doctor is using patula such that his tongue is suppressed. Then with other patula or other cotton wisp, he will stimulate the posterior pharyngeal wall. Now what will happen? The your ninth nerves carry the sensory information. Your ninth nerve carry sensory information, and motor is by the 10th nerve. Motor is by the 10th nerve. So when you will tell the patient to open the mouth, and first you will, with the help of a tongue blade, suppose you are taking tongue blade, you will compress or press the tongue, and with the help of patula, you will stimulate the posterior pharyngeal wall of the patient. And if there is a cough in response to your stimulation, it means your gag reflex is positive and it is okay. And if there is no cough or there is no contraction of the posterior pharyngeal muscle, it means your gag reflex is absent. Okay, Arshita. So you will stimulate the Harshita in gag reflex. Sensory is done by ninth nerve and motor is done by 10th nerve. Okay. Sensory is done by ninth nerve and motor is done by 10th nerve. So you will stimulate the posterior pharyngeal wall. If there is a cuff reflex or if there is a contraction of the posterior pharyngeal muscle, it means that gag reflex is present. And if it is absent, if suppose if suppose you have pressed my tongue and you are stimulating my posterior pharyngeal wall with the help of a patula, and if I am doing that, it means cuff or gag reflex is present. Okay, and if this is absent, you will suspect a brainstem lesion. Okay, everyone, got this? Shall we move further? See here, you have to gently touch the posterior pharynx with the cotton applicator. In normal, there will be elevation of the uvula, contraction of muscle, contraction of muscle, and a cuff response is there, and a cuff response. Okay, reflex cuff occurs in response to a material entering deep into the cut this posterior pharyngeal wall. ठीक है? So Heather is asking that what if the reflex is low or absent? If reflex is absent, it means there is a damage to ninth and 10th nerve. It means there is a damage to medulla. Okay? It means there is damage to medulla. Okay? Shall we move further? Everyone got this concept? Okay, Heather, Rishali, Naveen, Harshita, Priyanka, are you comfortable now with this cuff reflex? So we will proceed with the other reflex. No, other is your other is your cuff reflex. So likewise, you are doing the gag reflex. There is something known as cuff reflex. How can you do cuff reflex? In suppose if there is a patient you can't do gag reflex, there you can do a cuff reflex. How? You can do it by a trachea suctioning with the help of a trachea suctioning. Generally, generally when we do suction, suppose you are posted in ward, in ANT ward, in surgery ward, medicine ward, generally we do the suction of the patient. So when you are doing suction, if patient gag reflex is present or cough is present, so when you do a suction, suddenly within 1 or 2, 3 seconds, patient will cough. So you can also get to know by this also. While do suctioning, patient also cough. So if you are not able to do gag reflex, you can see it by doing trachea suctioning also. Okay, everyone. Okay, everyone. Shall we move further? Okay. What all other things you can do? Now just see, this is a image given in Harrison of brainstem examination of brainstem reflex in coma. One is your corneal blink reflex. Yes, sir, we have understood about corneal blink reflex. That is done by your 5 and 7th nerve. Next is your respiratory center. We have seen the patterns. Other is your reflex conjugate eye movements. That is your vestibulo-ocular reflex. We have also done with this. Then is your pupillary light reflex. We have also done with it. So now everyone is clear with all the brainstem reflexes. Anyone having any doubt in brainstem reflex, just tell me in comment section. If you are comfortable in this brainstem reflection, we will move further. Just tell me if anyone having any doubt in brainstem reflex. Done? Everyone got this concept? Okay. So now we study some other conditions. There are some conditions in which there is bilateral small pupil is there. Bilateral small pupil is there, and which is reactive to light. Which is reactive to light. So what all are the conditions in which pupils is bilaterally small and it is reactive to light? These are your metabolic, encephalopathy. These are your metabolic encephalopathy or uremic encephalopathy. Because most probably next class will be on Tuesday and Wednesday, and next class will be about dementia. Okay, everyone. Next class will be most probably on Tuesday or Wednesday. It will be around 7 p.m. and it will be on dementia. Dheeraj, we are covering all topics of Harrison base. Na? So in Harrison, we are covering CNS symptoms right now. So after this, my previous lectures are also present. Dizziness, vertigo, UMN syncope. You can see this previous lecture also. And yeah, Harshita, we will be finishing all Harrison. This is all Harrison based discussion. We are covering everything by chapter by chapter. Other is your hepatic failure. If all of you are liking this lecture, just comment on the comment section of your YouTube, not in live section, on proper comment. Okay. If you are okay with the lecture, if you are liking this lecture, and if you want any further, any kind of thing, just comment on the normal YouTube on my video. Okay, everyone. So in hepatic failure, there is a fulminant hepatic failure. So in these organs, there is increase in ammonia, increase in urea. So in all this condition, you can found that there are bilateral small pupil which are reactive to lights. Okay, other condition. Next come pinpoint pupil. Yeah, Rishali, we are covering whole Harrison because I have come to know that many of you who are studying right now, uh, your concepts are some about weak, especially neuro and CVS topic, and you are not able to understand Harrison when you are reading. So we by this Harrison based series, we will be covering all parts of Harrison such that your knowledge should be upgraded and your basic concept should be clear so that whenever you are going for practice as a doctor, you should be comfortable. Thank you, Naveen. So, can you tell me the can you tell me all the condition in which pinpoint pupil is there? So, pinpoint pupil are present in opioid poisoning, opioid poisoning, and also in pontine hemorrhage. थैंक यू ऋषाली, अगर टाइम मिला तो मैं जरूर सेलिब्रेट करूंगा. एज अ डॉक्टर वी जनरली डोंट गेट टाइम ना. सो so in opioid poisoning and pontine hemorrhage both have a pinpoint pupil. So how can we differentiate between कि ये opioid poisoning है, pontine hemorrhage है? So in opioid poisoning, temperature, thank you. Uh, um, this is complement or something else. So we are dealing with opioid poisoning. In opioid poisoning, so it is a practice now. I have a long practice of talking with girls. So this practice helps you. जब ये ऑन हो ना कि लड़कियों का नेचर कैसा होता है ना, थोड़ा लड़कियों की बातें ज्यादा सुननी पड़ती है ना, क्या कर सकते हैं. लाइफ इज ऑल अबाउट लिसनिंग टू गर्ल्स. लाइफ इज ऑल अबाउट लिसनिंग टू गर्ल्स, not listening to boys. So you have to be patient, you have to listen them. There is nothing you can do. So only just you have to sit there and you have to listen them. Only one thing you can do, nothing more than. If you do anything extra, your conversation is blown out. So just sit silent and listen them. So in opioid poisoning, temperature decreases, but in spontaneous hemorrhage, temperature increases. Yeah, Dheeraj, we will explain it in next lecture. Okay. In spontaneous hemorrhage, temperature increases. In this, respiratory rate, yeah, that's the secret of happy life. And one who crack it as much earlier as possible, he will be as much as happy earlier. If you crack this code late, you will be happy late. If you crack this code as much as earlier, you will be happy as much as earlier. I have cracked this code in my school time. So it, it is up to you when you crack this code. So in Ponte Hamlet, maybe Naveen, they are saying it from 2027, maybe, most probably. So in Ponte Hamlet, temperature increases and respiratory rate also increases. But in opioid, temperature decreases and respiratory rate also decreases. And we all know that opioid poisoning will respond to naloxone treatment. Will respond to naloxone treatment. This how you can differentiate between opioid poisoning and pontine hemorrhage. Okay, everyone? Yeah, naloxone is the antidote of opioid. So if you have any confusion, is this opioid poisoning or pontine hemorrhage? Either you can take history, his attendant or relatives will tell that yeah, he has he has taken some opioid kinds of drugs, or you can give a naloxone treatment also. Okay. Next comes your other concept of your ocular ocular bobbing, and other concept is your of ocular dipping. So ocular bobbing and ocular dipping are your vertical saccadic movements. Are you vertical saccadic movement? So what happens in ocular bobbing? B for bobbing and D for dipping. So dipping is present in diffuse cortical anoxia. ठीक है, D for dipping, B for diffuse cortical anoxia, and B for bobbing, it is present in basilar artery stroke. B for bobbing, B for basilar. And what is bobbing? In bobbing, in ocular bobbing, there is brisk downward movement. Yeah, brisk downward movement and slow upward movement. Slow upward movement like this. This is your brisk downward movement, but slow upward movement. And ocular dipping is just opposite to this. In this slow downward movement, but fast upward movement. Okay, got ocular dipping and ocular bobbing. Bobbing, B for bobbing, basilar artery stroke. D for dipping, diffuse cortical stroke. D for dip, ocular dipping मतलब क्या है? आई डिप कर रही है बट धीरे धीरे. यू कैन अंडरस्टैंड फ्रॉम नेम ना, ऑक्यूलर डिपिंग. डिपिंग, व्हाट डज डिपिंग स्टैंड? कि डिप करते हुए दिखेगा. नॉर्मली व्हेन यू आर मूविंग योर आईज रैपिडली, कैन यू सी your eyes? No, eyes go from one point to other. That is the, by God nature what we have given, our saccadic movements are there na. So I suddenly move from one place to another. But if you are seeing the slow eye movement, dipping is there. Slow in downward movement, slow in downward movement, then it is your dipping. And if upward movement is slow, it is your bobbing. So everyone got this concept, ocular bobbing and dipping? Shall we move further? Okay. Now, now other thing, there is another test also. There is another test also which we can do, which we can do in patient of coma. That is your apnea test. That is your apnea test. And this is a very important test. That is your apnea test. Now, how will you do this apnea test? First, we will give patient. First, we will give patient 100% ऑक्सीजन. क्या करेंगे हम पेशेंट को? पहले हम 100% ऑक्सीजन देंगे. कितनी देर तक के लिए? We will give for 10 minutes. Okay, ठीक है. After that, we will perform a ABG. We will perform a ABG, and on ABG we will see that PO2 should be above 200 mm Hg. ठीक है. So we are performing an apnea test because we all know that in coma, brain stem is damaged, your respiratory center is damaged. So we are doing apnea test. For apnea test, what we will do? First, we will give patient a 100% oxygen for 10 minutes, such that when we perform ABG after 10 minutes, his or her PO2 should be above 200 mm Hg. ठीक है सर, ये हो गया. After that, what we will do? We will disconnect. We will disconnect the patient. We will disconnect the patient from oxygen source. We will disconnect the patient from oxygen source. ठीक है. And now what will happen? We all know that this patient is in coma because his brain stem is damaged, his respiratory center is damaged. This patient respiratory center is damaged because he is in brainstem death. ठीक है? So if you have disconnected him from oxygen, can he normally breathe? No. So there will be absence of spontaneous breathing. There will be absence of spontaneous breathing. No, not in this test. It is used in other tests, not in this test. ठीक है? We have done. So we have. So first, what we had done, 100% oxygen दे दी. उसके 10 मिनट तक. Then we have done ABG. In ABG, PO2 above 200 mmHg. Then we have disconnected from patient from oxygen source. Now, as patient respiratory center is damaged because brainstem death is there. So can patient breathe normally? No, there will be absence of spontaneous breathing. So what will happen? What will happen? There will be rise in PCO2. There will be rise in PCO2. We all know there will be rise in PCO2, and PCO2 now will be greater than 60 mm Hg, or rise greater than 20 mm Hg. How will we get to know this rise? We will do ABG again. So because the absence of spontaneous breathing, we have done ABG. In ABG, it is showing that PCO2 has rise greater than 60 mm Hg or rise greater than 20 mm Hg. ठीक है? अब now you all tell me that CO2 is a powerful stimulator of brain center. CO2 is a powerful stimulator of brain center. So can this CO2 stimulate the brain center? Yeah, but in this patient, the brain stem is damaged. The brain stem is damaged. So despite of this rise in CO2, despite of this rise in CO2, so despite of rise in CO2, you are not able to breathe because your brain stem is damaged. Because your brain stem is damaged. Yeah, Rishali, any patient who you are suspecting a brain stem death. So हमने क्या किया अपने टेस्ट में? We all know that patient is brain stem death, but we are confirming this by a test known as apnea test. We will first give patient 100% oxygen such that his PO2 greater than 200 mmHg. Okay. Then we will disconnect it from source. Okay. We all know that his brain stem is dead. His respiratory center is not working. So there will be absence of spontaneous breathing and it will lead to rise in PCO2. And we all know that rise in PCO2, that PCO2 is a powerful central stimulator. But as his brain stem is damaged, can this PCO2 stimulate brain stem? No. So there will be absence of breathing. So this how apnea test helps us to confirm the diagnosis of brain stem death. Anyone? Any doubt? No, Naveen. In this patient, it will not cause hyperventilation because brain stem is fully damaged. If brainstem is somehow normal, somehow bit of it is functioning, then it will do hyperventilation. That is kind stroke respiration. But if brainstem is completely damaged, your midbrain pons medullus completely gone away. If you are in completely brainstem death mode, so there will be no hyperventilation. Okay, Naveen, सबको समझ में आ गया? Shall we move further? Anyone doubt? किसी को डाउट है? Just tell me in comment section. Yeah, yeah, but we can do. But we should. But patient should be in coma. Punit, okay. Now we'll come to other test. That is your EEG finding. EEG finding. On EEG, what we will find? There will be flat isoelectric line. There will be flat isoelectric line on EEG. Okay, everyone. There will be flat electro flat isoelectric line on EEG. सबको समझ में आ गया यहाँ तक? जस्ट गिव मी थम्स अप अगर यहाँ तक सबको समझ में आ गया. ठीक है. No, no, Puneet, we are doing this apnea test only for 10 to 5 minutes. Your patient is already a brainstem death patient. What what will happen? Nothing will happen. Patient is already brainstem. We are just only confirming a diagnosis because if patient is a brainstem death, before you label him brainstem death, you should confirm by one or two doctors that is brainstem death patient. Because in brainstem death patient, your your brain is not working, but your body is working. So these patients help us for organ donation. These patients help us for organ donation. So that's why we have to confirm the diagnosis based on that. That's why we are doing the patient. This will not harm the patient because already patient is brainstem vegetative state. What can further will happen? Nothing will happen further. Now we'll come to some DDs, some disease that can mimic brain death. That can mimic the brain death. These are also known as pseudocoma. Pseudocoma. Okay. First, is your logged in syndrome. First is your logged in syndrome. ठीक है. कैसे होता है? ड्यू टू एम्बोलस इन basilar artery. Okay. So there is quadriparesis. There is quadriparesis, but patient can respond. But patient can respond. Okay. समझ में आया? तो logged in syndrome act as a pseudocoma. There is quadriparesis. There is complete weakness. But if you do any stimuli or if you patient can move his or eyes also. In coma patient can't move his eyes. But in logged in syndrome, he can move his eyes. Vertical movements can be there. That's why logged in syndrome is also known as pseudocoma. Okay. Other can be or other can be or hypothermia. Other can be or hypothermia. In hypothermia, what happens is that when your temperature is less than 28 degrees Celsius, when your temperature less than 28 degrees Celsius, your brain stem reflex, your brain stem reflex, they disappear. Your brainstem reflex disappear. And if your brainstem reflex disappear, what you will think? You will think patient is in coma, but actually patient was in hypothermia. So these all conditions can mimic your pseudocoma condition. Okay, everyone, got this concept? Yeah, in less than normally no, I am saying that in hypothermia when temperature goes below 28 degrees Celsius, then brainstem reflex disappears. Okay, in hypothermia, when temperature drops below 20 degrees Celsius, okay, then this reflexive disappears. Okay, now there is another phenomena. There is a phenomena. Many a time, many a times now, what happen now? Patient is sick, patient is in coma, and suddenly his attendant will come to you and say to you, "Sir, patient patient is moving his limbs. Patient is doing something." So you have to explain the patient that these are some normal reflex. And what kind of reflexes can be there in a coma patient? There is one sign. known as Lazarus sign. Known as Lazarus sign. What happened in this sign? There is a reflex. There is a reflex which originates from your spinal cord. In this reflection, what happened? In coma patient, in coma patient, patient briefly raise their arms and drop them on their chest. ठीक है? अब see, there is a phenomenon Lazarus sign. What happens? That patient will be sitting like just normally, and suddenly his hand will be flexed and hands will be on chest. You are seeing this patient, he is normally in coma, and suddenly this patient is flexing his arm. This patient is flexing his arm. No, Rishal. Patient is flexing his arm, and patient attendant will come to you. Sir, my patient limbs are moving, and you were saying like that patient was in brain death. So you have to explain the patient. Patient is in brainstem death, but his or her spinal cord is intact. His or her spinal cord is intact, and this Lazarus sign or reflex is mediated by spinal cord. It is mediated by spinal cord, not by brainstem. That's why this Lazarus sign is happening in the patient. Okay, everyone, understood? Just give me a thumbs up. Why Lazarus sign is happening? Because brainstem is dead. Okay, fine, but spinal cord is intact now. That's why this reflex is happening. Okay, everyone. Okay. Now, sometimes ना attendant will come to you and they will say, sir, patient की hand movements हो रही है. They will say, patient की hand movements हो रही है. So sometimes there are some twitching of muscles in this comatose patient. Sometimes there is some twitching of the muscle, but gross movement is absent. Gross movement is absent, but some kind of twitching can be there. So you have to explain this thing to patient, because patient will come to you again and again. Sir, आपने बोला था ब्रेन स्टेम डेथ है, बट पेशेंट की लिम्स तो मूव कर रहे हैं, पेशेंट की उंगलियां तो मूव कर रही है. So you will have to tell them that gross movement are absent. Some kind of twitching can be present normally. So twitching of finger, yeah, spontaneously. Twitching of finger and toes can be there, but gross spontaneous movement is absent. Is absent. Other thing, क्या क्या in these patient will your deep tendon reflex will come? Anyone can tell me, in these patient will your deep tendon reflex will be present or not? Just tell me. In these patient deep tendon reflex will be present or not? Will in these patient your deep tendon reflex will be present or not? Just tell me. Can anyone tell me? Arya is saying no. Anyone? Will in these patient your deep tendon reflex will be present or not? Everyone is saying no. Okay. Anyone? Okay. They are also saying no. Beta, deep tendon reflex is mediated by UMN as well as LMN. Here UMN is not functioning, but LMN is functioning now. See, this is your spinal cord. Okay. This is your muscle. Now, these are alpha motor neurons. Okay, these are alpha motor neurons. ठीक है, and this is a muscle, this is a muscle fiber, and there is a muscle spindle, and here are sensory input going. ठीक है, now your UML is not there, but your LMN is there ना, your reflex pathway is there ना, so DTR reflex can be present, can be present. So you have to tell all these things to the patient attendants or relatives, that there can be dependent effects present also. Normal twitching can be there. This Lazarus sign or reflex can be there. So you don't have to confuse it with other things. Patient is brain dead, but due to spinal cord intact, these reflexes and all these things can be present. Okay, everyone. Puneet, Rishali, Naveen Patola, everyone got this concept? Yeah. Very good. Yeah, Puneet. Because your spinal cord is intact, na? Okay. Now we will come to last but not the least is your treatment part of coma. Okay. Patient is coming to you in casualty or emergency. Someone has said to you that we are sending a patient of coma to you. What first drug or treatment you will give to that patient? Just tell me in comment section. What first drug or treatment you will give to a patient of comatose coming to you in emergency? You are intern posted there, or you are a junior resident posted there, or you are a senior resident you're posted there. If a comatose patient is coming to you in emergency, which drug or treatment you will first give to that patient? Naveen, Arya, Grishali, first treatment what you will give to patient of coma coming to you in emergency? Anyone? Mannitol, Harshita. Mannitol is given in raised ICP. For raised ICP, you have to check all things. And raised ICP can cause coma, but every time coma can't be due to raised ICP. First thing, the most important basic thing is your hypoglycemia. Maximum coma patients are due to hypoglycemia. So you first have to correct the sugar part. Hypoglycemia. You first will give IV dextrose. The most simple thing you can give. Better, you have to start from simple things. You have to start from simple things. First, you will think of glucose. Hypoglycemia, you will give IV dextrose. Okay. Next, if a patient is of raised ICP, then you will give mannitol. Good Harshita Prenka. Harshita Prenka, you are, is it this one name or two girls? Two girls messaging simultaneously, or it is a one girl? Harshita Prenka. You will give mannitol. Very good. So why have you put on such a name? Harshita Prenka. Okay. So other is, if there is any alcoholic, now tell me if there is alcoholic with hypoglycemia. With hypoglycemia. There is alcoholic with hypoglycemia. What you will give to a patient who is coming to you alcoholic है, hypoglycemia के साथ आया है? What you will first drug you will give to a patient of alcoholic with hypoglycemia? Yeah, Dheeraj. First you will give thiamine, then you will give glucose. Because if you give glucose earlier, glucose will utilize all remaining thiamine and patient can land to one encephalopathy. Uh, Puneet is like, वो स्त्री है, वो कुछ भी कर सकती है. या यू आर राइट पुनीत, आई एम विद यू. वो कुछ भी कर सकती है. यू हैव टू रिस्पेक्ट हर. ओके, इन अल्कोहल विद Yeah, Heather, for that you have to check RBS, na? You just a small investigation that is of random blood sugar you can do. In alcoholic with hypoglycemia, you will first give thiamine and then glucose. Okay? हाँ हाँ रिशाली बिल्कुल देर कैन बी अंकल herniation and it can lead to raised ICP and patient can end to coma. Next is your opioid opioid toxicity. So what drug will you give in opioid toxicity? Anyone in comment section? A patient is coming to a comatose state and someone is saying that this patient generally do a opioid toxicity and he is a IV drug abuser also. पेशेंट क्या है आईवी ड्रग अब्यूजर है स्किन में मार्क्स है देयर आर स्किन मार्क्स naloxone very good you will give naloxone okay next there is a patient of stroke what you will give there is a patient of stroke landing into coma patient there is a patient of coma you have done general basic routine investigation of metabolic okay you have ruled out then you have sent patient for MRI and MRI what you will think that patient is having stroke what you will give yeah Naveen these all are the basic oxygen you have to put the patient in oxygen Naveen any kind of stroke generally what we do in stroke we do thrombolysis or embolectomy yeah you will do you will call you will call neurosurgeon for that okay if there is a raised acid patient you will also call neurosurgeon for that for these EDHs you will call neurosurgeon okay Puneet next is your diazepam overdose next is your diazepam overdose can anyone tell me what is the treatment of choice in diazepam overdose what is the drug of choice in diazepam overdose it is your fluema okay yeah flumazenil there is a something concept known as of coma cocktail coma cocktail likewise many times when we go in party and we are confused कि क्या पीना है बियर पीनी है विस्की पीनी है वोडका पीनी है एंड वी से कि कॉकटेल ले आओ क्या ले आओ कॉकटेल ले आओ कुछ ना कुछ तो हिट होगा कुछ ना कुछ तो हिट होगा ऐसे ही देयर इज अ कोमा कॉकटेल इन विच देयर आर थ्री और फोर ड्रग्स आर गिवन एज फॉर एज अ ट्रीटमेंट कुछ ना कुछ तो हिट करेगा ओके एवरीवन there is something known as coma cocktail there is something known as coma cocktail it consists of dextrose dextrose plus flumazenil plus naloxone plus thiamine ठीक है पेशेंट आया कोमेटोज हम उसको क्या देंगे कोमा कॉकटेल कुछ ना कुछ तो हिट करेगा कुछ ना कुछ तो हिट जरूर करेगा ठीक है ये कोमा कॉकटेल हमारे पार्टी वालों के लिए नहीं है ये कोमा कॉकटेल पेशेंट्स के लिए है देयर इज अ मिक्सचर ऑफ 3 or 4 ड्रग्स व्हिच वी आर गिविंग सच दैट कुछ ना कुछ तो पेशेंट को हिट करेगा ओके एवरीवन नो नो जनरली इन कोमा कॉकटेल फास्टिंग इज नॉट गिवन या अरे ना आई विल मेक अ कॉकटेल फॉर यू एंड आई विल गिव इट टू यू हाँ हाँ, ये रिशाली इज राइट ना। शोक की अप्सराओं से हमें अमृत पीना पड़ेगा। सो नेक्स्ट इज योर प्रोग्नोसिस। Next is your prognosis. So, what we have seen that metabolic coma, in metabolic coma has a good prognosis, has a good prognosis because because they are, yeah, yeah, you are right. Whenever is the this topic comes, Arya nerve becomes active. So in metabolic coma, good prognosis there because they are many times they are reversible condition. They are reversible condition. And if there is a structural coma, it generally carries a bad prognosis. It generally carries a bad prognosis. ठीक है, everyone? So we are finishing here our topic of coma. Everyone, anyone, any doubt regarding coma, or just we summarize briefly about coma? Anyone having any doubt related to coma? How to approach? How to do neurological examination? How to give treatment? Anyone having any doubt? Or should we just give a brief summary? So, suppose a patient has come to you with coma. Okay, first, what you have to do, you have to take a proper history and examination. First, what you will rule out, you will first rule out all the metabolic causes. You will rule out all the metabolic causes. After this, you will check for raised ICP. Okay, then you will do brainstem reflexes. You will do brainstem reflexes. Okay, then you will confirm it by imaging. You will confirm it by imaging like MRI. Okay, after confirming it by imaging, you will proceed with treatment. If metabolic, I have already told you have to replace the electrolyte or whatever condition is there, or you can give coma cocktail. And generally, the patient who are having structural damage, they have generally bad prognosis. So everyone, before we wind up this lecture, just tell me the most important reflex of brainstem you will do in comatose patient. The most important brainstem reflex that you will do in a comatose patient. Just tell me in comment section. The most important reflex that you will do in a comatose patient. Just tell me in comment section before we wind up this lecture. The most important brainstem reflex that you will do in a comatose patient. Naveen, Rishali, Arya, anyone. The most important reflex that you will do in a comatose patient. Anyone? The most important reflex that you will do to check for brainstem reflex. One reflex, most important reflex you will do, and you will be damn sure that it is a patient is in coma or brainstem death. Anyone? Puneet, Aryan, Dheeraj, very good. VOR. You will rule out cervical spine trauma by doing X-ray, and then you will do vestibular reflex. You will rotate the patient head to one direction, and if the eyes are moving in the same direction, it is vestibular ocular reflex is absent. Patient is in brainstem death. Patient is in coma. Okay, everyone. So thank you and good night. We will do next lecture on Tuesday or Wednesday around 7 p.m. It will be on dementia most probably. Okay, so you just read out dementia. We will proceed with dementia on next class. Okay, everyone. Good night and like, share, and subscribe. Okay, or if you are having any doubt, just tell me in comment section before we finish. Any doubt, just tell me. Okay.